Okay, is that any better?
Much better. Good morning to everyone who's joining us live. We are so happy to be able to co-host this morning's symposium with the Sylvester Comprehensive Cancer Center. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, and I'm going to have the opportunity later on to tell all of our virtual guests about our foundation. In the meantime, what I want to do this morning is to be sure and thank Sylvester for co-hosting this event. I want to thank Dr. Lutsky, who is the Director of Cutaneous Oncology Services, for putting together today's agenda and for serving as our moderator. And of course, I want to thank our esteemed panelists who will be presenting cutting-edge information on melanoma treatments and research. We have planned for and anticipated your questions that you will have for our panelists today. We'll have 2 live Q&A sessions, one that will occur about 2:15 following Dr. McKean's presentation, and then another that will happen at the end of the symposium. For those who are viewing, if you're viewing through Zoom, what you can do is look at the bottom of your screen and you'll see a series of tabs. One of those says Q&A. Just put your questions in there and Dr. Lutsky will be able to see them and then disseminate them to our panelists during our live Q&A session. If you are viewing via Facebook or YouTube Live, you can just put your question into the comments field and we'll transfer it over for Dr. Lutsky. And so with that, I'm going to turn the symposium over to Dr. Lutsky again with my thanks so that he can offer his welcoming remarks and introductions. Dr. Lutsky?
Thank you, Ann. Good morning and welcome to the Living with Melanoma Symposium at University of Miami Cancer Center. We very much appreciate our partnership with AIM at Melanoma in their national and global efforts to bring up-to-date and practical information to patients affected by melanoma and other skin malignancies. Today, we're very fortunate to have a group of amazing skin cancer specialists who will discuss various topics of interest during the symposium. And as Ann said, we encourage the audience to be very interactive and ask questions during the 2 Q&A sessions. So without further ado, I'll briefly introduce our speakers for today. Dr. Jennifer Tang is a dermatologist at Sylvester Cancer Center. She's an associate professor of dermatology and cutaneous surgery, and she's going to be talking to us about Mohs surgery. Dr. Jessica Crystal is a surgical oncologist here at Sylvester Cancer Center, and she's an assistant professor of surgery in the Division of Surgical Oncology. She will be discussing indications for neoadjuvant therapy in patients with melanoma. Dr. Meredith McKean is a medical oncologist and director of the Melanoma and Skin Cancer Research Program at Sarah Cannon Research Institute in Nashville. Dr. McKean will be discussing advances in the treatment of metastatic and advanced melanoma. We'll then have the Q&A session after that and a break, and then we're going to go to the second portion of our symposium. They will start with Dr. Leonel Hernandez-Aya, who is a medical oncologist and associate professor in the Department of Medicine at Sylvester Comprehensive Cancer Center. He will talk about the new development of cell therapy as an option to treat patients with melanoma. And finally, I will discuss uveal melanoma, which is a rare type of melanoma that now that we have now good options for treatment. I'm a medical oncologist. I'm the director of the cutaneous oncology services here at the University of Miami. So I believe we can now start with Dr. Tank, and I will mute myself. Dr.
Good morning, everyone, and thank you for the invitation to speak to you guys today and for the opportunity to educate you on the role of Mohs surgery for melanoma. Here are my disclosures that are not relevant to the topic of discussion today. And as an outline, I'll be describing Mohs micrographic surgery and describing the appropriate use criteria that we use to define when we should use Mohs surgery. And then finally, review the various comprehensive histologic evaluation techniques, whether that be slow Mohs or Mohs with immunostains. So Mohs micrographic surgery, this was a technique that was first started in the 1930s by Dr. Frederick Mohs. And this is frozen section, 100% microscopic tissue margin examination. And this technique allows for precise excision and mapping of the tumor. And it allows us the ability to immediately re-excise residual cancerous tissue on the same visit. This allows for maximum conservation of normal or non-cancerous skin, and it has the highest evidence-based cure rates for skin cancer. So a little bit about the procedure itself. It's done on an outpatient basis, usually in the clinic setting in an exam room. It's very safe because we use local anesthetic, so this obviates the need for the operating room and general anesthesia. And again, we have the luxury of being able to remove the tumor and perform the reconstruction on the same day. And with this technique, we're able to decrease surgical morbidity because we're preserving normal tissue so that we're able to provide the least complicated repair reconstruction possible. So this is a schematic taken from the American College of Mohs Surgery. So why do we do Mohs surgery? It's because the roots of a skin cancer often extend beyond the visible portions that we see with our naked eye. And if these roots are not removed, the skin cancer will recur. So here's a schematic here. Local anesthesia is injected in the office and we numb the entire lesion. And the visible portion to our trained eye is removed and with a very small narrow margin around the tumor, typically for non-melanoma skin cancer, 1 to 2 millimeters, a little wider for melanoma, that we'll describe later. And once that's removed, we stop the oozing and we put a temporary bandage on while the surgeon brings the tissue to the on-site lab. We section the tissue and we ink it with dye and we map it out on a piece of paper. The histotechnician then divides the tissue and freezes it and then mounts it on the cryostat, which is a device that cuts the tissue. And we process it in a way where we cut the tissue in a horizontal or flat fashion, and we put it on a slide. Once that's mounted on the slide, it goes through a series of various stains, and then it's finally brought to us, and we're able to examine the slide under the microscope, and we're able to view 100% of the margins, meaning we're able to see all the peripheral or surrounding margins, and also the deep margin. And with that map on my side, I'm able to target and map out exactly where there's remaining skin cancer. So then I go back into the patient's exam room and we're able to cut a little wider, a little deeper, depending on what the map dictates from my read. And sometimes that process it's one cut, sometimes it's several cuts. It truly depends on the cancer itself. And once that is completely removed, then we're left to deal with the defect, whether we do a skin graft, a flap reconstruction, or even a linear line repair. So how does that differ from conventional excision? So when we simply excise with a wide margin, we take that margin and we create an ellipse that we see here because usually we're immediately closing the defect. And I want to highlight here, I want you to pay attention to that peripheral tumor that's depicted here. So when we take that specimen out, we send that typically to the outside lab. And here, the lab processes it in a bread loaf section fashion, meaning we cut in a vertical way through the tissue, and typically you will get about 6 to 8 slides per specimen, depending on how big the piece is. So here it's a pretty accurate example of the 6 slides that we would get from that specimen. And from these 6 slides, here you would say that all the margins are clear. However, we're not able to capture that outside peripheral deep margin. So that's seen here, and we're not cutting into that section. So this differs from Mohs micrographic surgery because typically when I remove it only in that circular fashion because I don't have to cut those and I don't have to remove that ellipse yet. So once that's removed, again, it's highlighting that external deep tumor island here. And it's sectioned by the histotechnician, but the way that we mount it is we mount that bottom, that deep margin onto the glass slide, so we're able to see it directly. So rather than cutting it vertically. So I know it's hard. It's very hard to explain to patients, but sometimes I describe it as like a Reese's Pieces cup where we're truly inverting the specimen so that we're able to see everything that's closer to your skin and first. So the flaws of conventional excision is that when we do those serial vertical cross sections or the bread loafing, where in studies we're only actually examining less than 1%, less than 0.1% of the true at-risk margin. So when you're sectioning at those normal intervals, there's a 19% chance of detecting a positive margin at those normal intervals. And in an ideal world, we would have to cut at very tiny intervals of 0.1 millimeter in order to detect 100% of the positive margin. So that's where some of the criticisms of conventional excision exist. So then why aren't we doing Mohs surgery for every cancer? So frankly, it would definitely be overkill and would exhaust the healthcare system. It's typically not used in locations where there's lots of tissue reservoirs, so the trunk and extremities, where tissue conservation is not as critical. And also the recurrence rates are not as high in some of these lower risk areas that I will further expand on. So this led to a group of dermatologists from the American Academy of Dermatology and other boards such as the College of Mohs Surgeons, the American Society of Dermatologic Surgeons, and the Mohs Society. About in 2012, there was a consensus statement where we attempted to define the appropriateness of Mohs surgery dependent on the tumor type, the location where it occurs, the size of the cancer, and the patient characteristics. And even back then, with Mohs with immunostains in its infancy, it deemed that Mohs was probably appropriate for melanoma in situ or lentigo maligna on various locations, including high-risk locations, sorry, including the cheeks, forehead, scalp, neck, jawline, and the shins. Even higher risk areas are the mass distribution of the face, so meaning the central face, the genitals, the hands, feet, and ankles. Tumors where incomplete excision has been performed is usually indicated, and for recurrent tumors, that's probably also appropriate as well and not dependent on where the location is. So moving on, so there's a body that you probably are familiar with, the National Comprehensive Cancer Network, which is a multidisciplinary group of various cancer experts that they gather and formulate guidelines for various tumor types. And fortunately, melanoma, we have these. So the NCCN guidelines for melanoma excision, when we look at the data that's used to make those recommendations, they're based on 6 randomized prospective trials where the overwhelming majority, 99% of those cases, were melanomas on trunk and proximal extremity. So that's what we're basing our treatment recommendations on. And when you look at specialty sites, meaning high risk, head and neck sites, or genitals, hands and feet, the melanoma margin trials only included 37 melanomas. So that represents less than 1% of what the population in those guidelines are. We now know that anatomic location is a crucial predictor of complications and complexity of conventional or normal wide local excision. So for that reason, most micrographic surgery fills a gap in the NCCN guidelines for melanomas that are on specialty sites. So again, I want to highlight on specialty sites, so not for everyone. So I want you to, think of this as a pretty simple, rule of thumb. So rule of twos and rule of tens. What does this mean? So rule of twos, this pertains to the complication rates after conventional excision of trunk and proximal extremity melanomas. So these are what we call lower risk sites, and lower risk because there's only 2% risk of upstaging the tumor after it's been completely removed. There's only a 2% risk of having a positive excision margin when we excise the typical margins that NCCN recommends. And there's only a 2% chance of local recurrence. However, the rule of tens, this applies to the complication rates after conventional excision of specialty site melanomas. And here you can see the drastic difference. There's a 10% risk of upstaging the tumor stage. There's a 10% risk of having a positive excision margin when we use those recommended excision margin recommendations, a 10% risk of local recurrence. And here's another 10, so although not a percentage, there's a 10% increased likelihood of having to do a more complicated reconstruction, such as a flap or graft. So this is this is what I use to explain to patients when I'm describing why Mohs is a preferred modality on these specialty sites. So because of all this, so there's been a great body of knowledge that's been in the past decade on Mohs for melanoma. So in the NCCN, acknowledges and incorporates this literature into some of the recommendations now, where Mohs may be considered for minimally invasive T1A melanoma. So these are melanomas these are superficial melanomas that are less than 0.8 millimeters in Breslow depth and also without ulceration in anatomically constrained areas. So these are specialty sites, face, ears, and acral sites, meaning the hands and feet. And when Mohs is not available, you can use other modalities such as stage excision, where you're doing comprehensive histologic assessment. When Mohs is performed, it's critical that that central deep bulking specimen that we remove is either sent for permanent section analysis or frozen section and cut in that vertical fashion in order to truly analyze the depth of the melanoma, because that provides the full staging information. This is in the finer print of NCCN guidelines. So in specific situations, so for large or poorly defined melanoma in situs, in lenticle maligna, which are melanomas that are arising in chronic sun-exposed skin, or in acral lentiginous subtypes, again, the ones on hands and feet. And then the ones, again, with a very minimal invasive component, the superficial ones that are less than 0.8 millimeters. They acknowledge that surgical margins of greater than 0.5 centimeters may be necessary, and techniques for comprehensive histologic evaluation and margin should be considered. So when it's not available, we know that in these locations, excision and margins of even greater than a centimeter may be even needed. But they strongly advocate that if Mohs is performed, to incorporate frozen section immunohistochemistry stains to assist in accurate interpretation. So I'll expand on that in the next slide. So the two methods of comprehensive histologic examination are slow Mohs, and how does this differ? So this is as outpatient procedure, also using local anesthetic. However, here the specimen is sent for stat permanent section, so we rely on the outside dermatopathologist to read this in their lab. And the inconvenience here is that it ranges anywhere from 1 to 3 days for the turnaround time to let us know whether we need to cut more or if the patient is ready for reconstruction. So because of that, the entire process may take up to 2 weeks. So meaning that the patients may have an open wound for that duration. That differs from what we call Mohs with immunostains because here we're removing the tumor layer by layer in the office, but we have real-time updates because we have an on-site lab where we're able to see the melanoma cells with with immunostain called MART1. However, for those who have had Mohs surgery before in the audience, this differs from conventional Mohs because each cut takes 2 to 3 hours to get a result because of the special processing time or processing it takes to highlight the melanoma cells. And the benefit here is that we have the definitive surgical treatment and reconstruction that can be performed on the same day. So Mohs with MART1, why is the special stain needed? It's because the atypical melanoma or melanocytes are very difficult to visualize in conventional frozen section, which is hemotoxin and eosin. So we rely on the immunohistochemistry stain to aid in highlighting the melanocytes or melanoma. There are various ones that can be used to see the melanoma cells, but the one that's more popular, more conventional is MART1, and it's been shown to have superior sensitivity compared to other melanoma markers. There's also been validation that MART1 frozen sections are as accurate as the typical, permanent section slides that we send to the outside pathologist. And here we retain the most advantage of having the pathologic assessment of the entire surgical margin and increasing the ability to identify the subclinical tumor. So I want to highlight some important papers looking at Mohs versus excision for head and neck melanomas. This is a systematic review, which is a high-level evidence of looking at why local excision and Mohs with and without immunohistochemistry. So LR here represents local recurrence, and I want to highlight here in the systematic review of 60 studies that the wide local excision recurrence rate for head and neck melanomas was greater than 7%, almost 8%. When you look at it for Mohs surgery, without immunohistochemistry, which was the way that we used to do it probably 15 years ago, better, but still, still not great. And then with the incorporation of immunohistochemistry, we further reduced that recurrence rate from 3.3 to about 0.5%. And this has been replicated in a University of Pennsylvania cohort. They also saw that the local recurrence with Mohs surgery of only about 0.5% for head and neck melanomas. And for excision, they had a local recurrence rate of almost 10%. So here are some slides I want to show you. So this is a typical H&E slide of a melanoma slide. So we produce both normal slides because this aids the immunohistochemistry slides, but it's hard for you to interpret. But trust me, this is a very difficult slide to interpret. What's melanoma, what's melanocyte, what's a normal skin cell. And so that's why we rely on the immunohistochemistry stain. So here we have a chromogen it's tagged by the antibody, and there's a chromogen that then highlights that antibody. And here you can see in this run here that there's increased melanocyte density, and here there's even a nest, so that signifies that that's melanoma in situ. So then I have my map to the side of me, and I'm able to mark that peripheral margin, and I'm able to go back immediately into the patient's room and re-excise that surrounding margin. So I want to close now with a case of mine, so showing the pitfalls of regular excision on the face. So this is a patient of mine who had a remote history of another melanoma on the nose back in 2006. When I first met her about 3 years ago, she was diagnosed with a separate melanoma in situ on the right cheek, highlighted here. So this was at a time when I was not doing Mohs with melanoma stains yet in the office. And I did the conventional excision with zero point 0.5 centimeter margins as recommended by our dermatology literature, by NCCN guidelines. And from the read from the pathologist, it was read as margins free. And this was immediately closed. So highlighting again where we convert that circle into an ellipse so we can do that immediate closure. She did well for about 20 months or so, and then in 2024, she unfortunately developed pigmentation along that scar, was biopsied again and confirmed a recurrent superficial melanoma here. So at this point, we were up and running with our Mohs with MART1 immunostains, and that's how I chose to treat her recurrent melanoma at this point. So all these circles, they mean something to me, but I'll translate to what they mean. So that inner circle is the clinical margin of the melanoma. So what we see with our naked eye. And then we take another 2 millimeters around it, and that's the piece that's taken for that central deep bulk. So that is processed in a vertical fashion for us for frozen sections, and also sent to the outside lab to further confirm that there's no true invasive component, as recommended by the NCCN. And that outside margin is what is the true margin for Mohs. And then that's taken with an additional 2 to 3 millimeters. So we don't deviate from the recommendations. We are still approaching it with the 0.5 millimeter margins for melanoma in situ, and for those rare superficial ones, we do take that full centimeter margin for superficial melanomas. So that previous, the histology slides were actually for her, so I did have to go back in for a second stage. And I want to highlight some of these dimensions because it's critical to know that, the 0.5 centimeter margins is definitely an underestimation of the margins that's needed to clear these tumors, especially in patients in South Florida that have a lot of sun damage. So her initial biopsy specimen dimensions were only about 1 centimeter, and her ultimate defect size was almost 3. So I definitely had to go way beyond the 0.5 millimeter margins to clear her. Albeit she did have a recurrent tumor, so those often do require wider resections. So the take-home points here. So the goal of Mohs surgery is 100% margin evaluation for complete tumor removal. It allows precise mapping for maximum preservation of normal skin. It's an option of providing same-day treatment and removal of the cancer and reconstruction. Most of the immunostains can provide lower recurrence rates and should be considered for high-risk sites only, so not for every melanoma that's out there. And thank you so much for your attention.
Thank you, Dr. Tang. I learned a lot about Mohs as well today. Thank you. So our next speaker is Dr. Jessica Crystal. Once you had your melanoma diagnosed and it's not a melanoma that is fit for Mohs surgery, then patients have to have their surgery. And there has been a lot of development in that area. Some of these more advanced melanomas now are treated with systemic therapy before they get their treatment. And Dr. Crystal is going to tell us who are those patients and how do we decide who needs systemic treatment before surgery. Dr. Crystal.
Great. Thanks, Jose. I'm Jessica Crystal. Nice to meet everyone. Thank you for joining us today, and thank you for the opportunity to present. Forgive my voice a little bit. I have a little bit of a cold. Today, we're going to be discussing, as Dr. Lutsky mentioned, surgical management in melanoma. When is systemic therapy needed beforehand? Hold on, let me just move this. Okay, sorry, my Zoom. I have nothing to disclose. Today, we'll be talking a little background about melanoma, some of the treatment plans, surgery, and systemic therapy, and our conclusions. So as far as melanoma goes, and I'm sure we'll touch on some of these points multiple times today, but they're important. Melanoma most commonly arises in the skin, cells called melanocytes, which produce pigment called melanin, and you can see that on the right. Although melanoma often starts in the skin cells, as shown, sometimes it can exist in non-sun-exposed areas, including in the eyes, mouth, or under the nails, which Dr. Lutsky is going to go into a little more later, those mucosal melanomas. And the non-sun exposed ones. Additionally, malignant melanoma represents only about 1% of all skin cancers, but there's a lot of attention to it because most of the deaths are a result of this type of cancer. In 2025, over 100,000 patients were diagnosed with malignant melanoma. Over 100,000 were diagnosed with melanoma in situ or precancer, and about roughly 8,430 patients died from melanoma in the US. Unfortunately, this is likely an underestimate of the true annual incidence, as many of these superficial and in situ melanomas are not reported. So sometimes patients are in the outpatient office and things are quote unquote burned off, or just a little small shave excision, and are not reported to the American Cancer Society when they're accumulating their data and their statistics for the year. We do find that there's increased incidence of new invasive melanomas over time, with over 46% new invasive diagnoses in the past 15 years. The median age of diagnosis is 59. When I'm examining a patient myself, Dr. Tang, or any of the panelists on here, we look for pigmented lesions that have the ABCDEs of melanoma. So we're looking for asymmetric borders. We're looking for the borders to be uneven. We're looking at more than one color, or the color of the lesion, looking if it's darker or not. We're looking at the diameter or the size, typically greater than 6 millimeters. And we're looking at evolution. Does it change in size, shape, color, or another trait? Typically, one of the key points I note in my patients is change, evolution. If they're seeing a change in any of their pigmented lesions, that's most concerning to me. When we're looking at risk factors for melanoma, there's personal or hereditary factors and then environmental factors. And these are different factors that we have that make you at elevated risk for melanoma. This includes male sex, age greater than 50, your skin type, frequent burning, multiple moles, immunosuppression, family history, including inherited genetic mutations, and then, of course, sun exposure, particularly tanning. When we think about melanoma, we have to think about how to stage it. And the staging helps guide us to tell you what your prognosis is. When we're looking at the stage of melanoma, the early stages are confined to the epidermis, or stage 0, or melanoma in situ. When it starts to progress further in the depth fashion, that's one of the key factors when we're staging melanoma we look at is the depth. We start getting into the more invasive components, and that's typically stage 1 and 2, are characterized by the depth of the melanoma seen under the microscope, in addition to some ulceration. As melanoma progresses, it has a tendency to then spread to the lymph nodes, which then makes it stage 3. The other component of stage 3 is other lymphatic involvement, like in something called in-transit disease. In-transit disease is lymphatic deposits of tumors that are not actually in the regional nodal basin. For the future components of this talk, I'm going to be referring heavily to the stage 3 population, as these are the ones that the neoadjuvant immunotherapy is best tested in. Subsequently, if melanoma spreads beyond the in-transit disease or beyond the lymph nodes, it's stage 4 disease. And stage 4 disease constitutes as melanoma spreading elsewhere in the body, including the brain, lung, bones, liver, intestines, and elsewhere. As mentioned, the staging of the disease guides us to what we can predict as the survival. And unfortunately, as melanoma progresses and spreads to the regional nodal basins and beyond, unfortunately, the 5-year survival rate declines. So patients who present with localized melanoma, stages 0, 1, and 2, have an excellent prognosis with a 98.4% 5-year survival rate. Unfortunately, that drops to 63.6% when patients have regional nodal disease or in-transit disease, and unfortunately to 22.5% for the metastatic melanoma patients. We'll discuss shortly the treatment for these different types of tumors. However, it's important to consider when we're considering which type of treatment, we take into account these survival rates in how to guide our patients to get excellent cancer control while also trying to limit the morbidity of the different treatments. Now, as far as treatments go, the main workhorse for melanoma is surgery, as Dr. Tang already alluded to. Now, Dr. Tang and I both work very closely when melanomas are just between typically stage 0 to 1, depending, as she already mentioned, on the location and the depth of the melanoma. When the melanoma starts to get a little bit deeper or in other sites of the body that are no longer suitable for Mohs surgery, the patient gets referred to me, and we perform one of the standard components of melanoma surgery, which is wide local excision. Wide local excision includes a removal of the skin and the underlying subcutaneous tissue down to what we call the fascia or the covering of the muscle. This allows for removal of all the tissue, what we believe should be all the tissue in the adjacent subcutaneous lymphatics to really clear out the area of the melanoma. The other component of this is helping us find a true diagnostic component of this surgery, as many patients present to us with just a biopsy. And by removing this space, we're able to get a better sense at the true depth of melanoma. Now, as far as the margins go, the margins are the space around the biopsy site, which we need to remove. And as you can see on the right, depending on the depth of melanoma, determines how wide of a margin we have to take circumferentially. So if it's pre-cancer, we only have to take 0.5 to 1 centimeter. If it's less than 1 millimeter in depth, we take 1 centimeter. And then beyond that, the 1 to 2 centimeters or 1 to 2 millimeter in depth, and then greater than 2 millimeters, you're in the 2 centimeter margin. Of note, these margins are currently being evaluated in a large randomized control trial called MELMAR, which recently closed to accrual and was available here at Sylvester Cancer Center, where we're trying to readdress the role of margins in these patients. Of note, we will potentially adjust those margins based upon location, as previously described by Dr. Tang. Now, another important component of our surgical approach to melanoma is evaluating the regional nodal basin. And there's 2 different types of surgery to evaluate the lymph nodes, and it depends on whether or not there's clinically node-positive disease. Clinically node-positive disease is disease that has cancer in it when the patient is encountered. So you either identify it on physical exam, or it's identified on imaging. And typically a needle biopsy or an excisional biopsy is performed to confirm tissue diagnosis or spread of melanoma. If this is involved, it then becomes stage 3 disease. However, some patients present to us with what we call clinically occult disease, meaning that we can't find any lymph node disease on physical exam ahead of surgery. However, there's microscopic disease present nonetheless. So typically in this situation, when we evaluate a patient, if we only identify a biopsy site change and we don't identify any abnormal lymph nodes ahead of surgery on physical exam or selective imaging, not every patient needs imaging, but selectively we'll use it, we'll then recommend for the patient something called a sentinel lymph node biopsy, which is injecting a radioactive tracer and blue dye around the primary tumor to identify the first lymph nodes where the cancer typically spread. We'll typically perform this in patients that have either ulcerated melanomas or once they start to get greater than 0.8 millimeters. Sorry about that. If there's any uncertainty in the actual depth, or if the risk of melanoma involvement in the sentinel lymph nodes is greater than 10%. Of note, sometimes Castle Biosciences has a genomic expression profiling test can be used to evaluate sentinel lymph node biopsy, but as a group, we're not yet all in agreement to use it. Now, that's when we have clinically node negative disease. And that sentinel lymph node biopsy is performed to identify little microscopic disease to tell us whether or not a patient's stage 3. For clinically node-positive patients, there's a different type of lymph node surgery we perform called a lymph node dissection or lymphadenectomy. And this surgery removes all the lymph nodes in a region. There's two different ways to think about this. One is a completion lymph node dissection, which is surgery performed after the sentinel lymph node biopsy to remove the remaining lymph nodes in the basin. So this happens when a patient has a sentinel lymph node biopsy. The melanoma is identified under the microscope in some of these lymph nodes that are removed. And then we deem that select patients may need this additional surgery to remove the additional lymph nodes. This was very much common practice in years in the past. However, a very large randomized trial was performed looking at the role of this completion lymph node dissection. And in fact, they found in majority of the patients, even with multiple poor prognostic factors, completion lymph node dissection was no longer necessary. So it's important to think about completion lymph node dissection in patients, but it's a tool that we use less frequently than in the past. Now, a similar surgery that's performed is a similar concept, but a slightly different name, is called therapeutic lymph node dissection. This is the same exact procedure as a completion lymph node dissection in the regards that we're removing all the regional lymph nodes in a basin. However, there was no sentinel lymph node performed initially because patients who receive a therapeutic lymph node dissection actually had a clinically node-positive disease a priori, meaning when the surgeon or the clinical team evaluated the patient, they identified a lymph node with disease prior to that surgery, and therefore at the time of surgery, they removed all the lymph nodes in that lymph node basin. The reason I brought up all these different surgical techniques are the different types of surgeries are used at different points in our subsequent trials looking at neoadjuvant immunotherapy. So that brings me to my next point and the next treatment that we have for melanoma, and that's immunotherapy. Immunotherapy is a type of medication that uses the body's immune system to attack cancer. There's different types of immunotherapies that are used. One of the initial ones studied was CTLA-4 inhibitors, or ipilimumab. And you could see on the chart how ipilimumab acts to bind to a CTLA-4 on a T cell and allows the immune system to fight its cancer. There's another type of immunotherapy called checkpoint inhibitors, which also work to release the body's immune system to allow the T cells that are already in your body to attack tumor cells and kill the cells. There's different types of checkpoint inhibitors, some that block PD-1 or PD-L1, and a newer type called LAG-3. The initial studies that were testing immunotherapy occurred in patients with metastatic disease, as many of our cancer systemic therapy studies go. And these initial studies showed a significant survival benefit. So once the medical community identified a survival benefit in immunotherapy, which was incredibly important because, as you recall, when patients hit the stage 4, unfortunately progress to the stage 4 amount of disease, their prognosis and 5-year survival drops dramatically. So the medical community then subsequently said, listen, if our immunotherapy is working so well in the metastatic setting, who else can we use that in? And this led to subsequent studies looking at adjuvant immunotherapy for patients with stage 3 disease. So here are 3 of the key trials that were used to identify using immunotherapy in what we call the adjuvant setting, meaning the patient got their surgery up front. So they typically got a wide local excision and either a sentinel lymph node biopsy, which ended up being positive, or a lymph node dissection because they had a positive lymph node up front. And they then treated the patient with various types of immunotherapy. EORTC 18071 looked at ipilimumab, Checkmate 238 looked at nivolumab versus ipilimumab, and then Keynote 054 looked at pembrolizumab. The key point here is all these studies had a positive benefit in some form of survival, may it be overall survival, recurrence-free survival, or distant metastasis survival for patients, and proved that immunotherapy should be a key component of treatment in patients with stage 3 disease. Of note, not there's no free lunch in the world, and certainly not in medicine. And the reason why they don't just give this immunotherapy to everyone is because immunotherapy does have its own side effects and its own toxicities, in specifically immune-related toxicities, including problems with the endocrine system, for instance, the adrenal, the pituitary, can cause diabetes, thyroid, it can cause colitis, it can cause pneumonitis, encephalitis, etc. So when they were looking at these studies, they only wanted to, some of the rationale for using it was who's going to benefit from this the most, whose risk-benefit ratio is going to be sufficient enough, there's going to be enough benefit that it's worthwhile to risk these side effects. So now that they saw those in the metastatic setting having a positive response and the adjuvant setting having a positive response, we started to look at who else can we help? And so people started looking at what we call neoadjuvant immunotherapy, which is immunotherapy upfront followed by surgery. And in principle, the reasoning or the rationale why we considered using it is because we felt that if the primary tumor was present, there was a larger source of tumor antigens for those immune cells to recognize. So when the checkpoint inhibitor came in or the immunotherapy came in and unleashed the immune cells that are already there to attack the tumor, there was more tumor present for those immune cells to attack. In addition, one of the added benefits of using neoadjuvant immunotherapy is if we saw how the patient was responding to the treatment. So we see that this is a immunotherapy sensitive tumor or not, we're then able to guide the patient to what the next steps are. So should we be continuing the same immunotherapy? Should we switch? Fortunately, recently, we've had a handful of studies looking at a bunch of different immunotherapy regimens. Should we change the immunotherapy regimen, or should we go ahead and just perform surgery? And of note, each of those decisions are individualized on each patient's amount of disease. So one of the very first studies looking at neoadjuvant immunotherapy was the SWOG S1801. This was a phase 2 randomized controlled trial evaluating patients with stage 3B to 4C melanoma that were amenable to surgical resection. There were two groups the patients were randomized in. The first group received 3 doses of neoadjuvant pembrolizumab, followed by surgery, followed by 15 doses of adjuvant pembrolizumab. Of note, typically these patients would have received some form of a wide local excision and typically a therapeutic lymph node dissection at the time, as they were presenting with clinically node-positive disease. The other arm was surgery followed by 1 year of adjuvant pembrolizumab. Treatment was continued until disease recurrence or unacceptable toxic effects developed. The neoadjuvant arm had a significantly longer event-free survival, 72% versus 49%, as you can see on the survival curve on the right. In addition, 28 of 132 patients receiving the neoadjuvant immunotherapy had a complete pathologic response. That means just those 3 cycles of immunotherapy completely killed all the tumor. Of note, 1 patient had complete imaging response, however, declined surgery. So we don't know if they truly had a path complete response, but after 31 months of follow-up, no disease was detected. Shortly after, or around the time that SWOG 1801 came up, an additional study from the multiple groups in Europe came out called OPAS and NEO, where they were looking at a slightly different regimens compared to just the single agent like SWOG 1801. So in OPAS and NEO, they looked at stage 3 melanoma patients, so lymph node disease and in-transit disease, and randomized patients to one of 3 different neoadjuvant dosing arms combining ipilimumab and nivolumab. They evaluated for both toxicity and efficacy. The arm that was the most benefit with the least toxicity was group B, 2 cycles of IPI plus 1 milligram per kilogram and nivolumab, 3 milligrams per kilogram once every 3 weeks. And this was very well tolerated with a very high pathologic complete response rate of 77%. Of note, this was used in a subsequent trial that I'm going to be talking about momentarily. One of the important findings from this study is that pathologic response to neoadjuvant therapy appeared to result in a durable and reliable surrogate for recurrence-free survival and overall survival. That's important because we sometimes don't know how to assess a response, and waiting for an overall survival benefit to determine whether or not a patient's responding to a treatment is a very long time to wait if you don't know what's happening, and it's difficult to guide the patient based upon that. So as mentioned, the subsequent study to Opasanio was the Prado trial, which used that Ipi-Nivo combination and then started to adjust what we do in the surgical realm of things. So I previously mentioned to you for stage 3 disease, we were typically removing the primary site, the wide local excision, followed by the lymph node dissection. The group in the Prado trial said, hey, if we're getting such dramatic pathologic complete responses and partial responses, why are we doing this big lymph node surgery that has multiple different side effects? So when I counsel patients on lymph node dissections, I warn them of those side effects, which include injury to major blood vessels. We're removing the lymphatic bearing tissue along major blood vessels in the extremities or in the neck. We are potentially can cause injury to major nerves that allow you to do many of the things you like to do. For instance, moving your arms and legs the way you like. It can result in numbness and pain. And in addition, significant lymphedema or significant swelling of the arm that sometimes is unreversible. So this study says, if we are getting such a dramatic response with immunotherapy alone, stimulated by the tumor being present up front, why are we bothering with this big surgery? So what they did is they removed the index lymph node, which is the largest lymph node metastasis at baseline, and then they removed it and looked at it under the microscope and determined what the response was, whether it was a major pathologic response, a partial response, or a non-response. Based upon that, they decided the subsequent treatments, whether they do that therapeutic lymph node dissection, the removal of all the lymph-bearing tissue, and then whether or not they surveilled those patients, or whether or not they give subsequent adjuvant immunotherapy. In this study, they showed that this selective approach to management of the path response was feasible, with a partial response rate of 72%. Therapeutic lymph node dissection was omitted in almost all the patients with a major pathologic response, and there was excellent relapse-free survival of 93 and 98%, and distant metastasis-free survival of 93 and 98% in the patients with the major pathologic response, dropped down to the mid-60s with the partial response, and 70% in patients with no response. An additional trial looking at immunotherapy up front looked at combo agent as well, but was also looking at de-escalating some of our treatment. But instead of de-escalating surgery, it was looking at de-escalating the adjuvant immunotherapy arm. So the Nadina trial looked at macroscopic stage 3 melanoma using 2 cycles of neoadjuvant ipilimumab plus nivolumab, and looked at patients who then got surgery versus patients who got surgery first, followed by adjuvant nivolumab. At the median follow-up of 9.9 months, the estimated 12-month event-free survival was 83.7% in the neoadjuvant arm and 57.2% in the adjuvant group, as you can see on the right. In the neoadjuvant group, 59% of the patients had a major pathologic response, compared to the 8% and 26% with a partial and non-response. Ultimately, the 12-month recurrence-free survival was 95.1% in the neoadjuvant arm, who had a major path response, and 57% in the non-response. These significant findings led to the conclusion that neoadjuvant immunotherapy is an excellent approach to patients with stage 3 disease. Unfortunately, these studies that I've previously mentioned are not yet powered to de-escalate surgery yet, but it gives us ideas for the future of how to guide our trials. So in conclusion, while melanoma can be an aggressive disease, we currently have many promising options for treatment. Using a combination of surgery and systemic therapy, particularly immunotherapy, can result in excellent control of disease. Future studies need to be performed to optimize the use of these modalities. Thank you.
Thank you, Dr. Crystal, for the excellent discussion on adjuvant and neoadjuvant therapy. So you've had your surgery, either neoadjuvant or adjuvant therapy, and unfortunately, after a few years and sometimes a few months, a test shows that the cancer has spread to other areas, you have developed metastatic disease. Uh, how do we approach melanoma at that stage? And I'm so happy we have Dr. Meredith McKing here, who is a star trialist and has been involved in many, many, many clinical trials for advanced melanoma. And she's going to give us her take on how to approach these patients today. Thank you, Dr. Meredith. Dr. McKing.
Great. Well, thank you so much for the opportunity to be here to speak with all of you today. Appreciate the invitation. So just wanted to touch on just some of the exciting kind of novel therapies coming through, maybe some things to consider as a patient or if you have a loved one with melanoma. And certainly, if nothing else, hopefully after these 20 minutes, you'll feel hopeful that there's a lot of options coming. So my topic is new and emerging treatments in melanoma. So it's really the Checkmate 067, that was the landmark trial for patients with metastatic disease. And this has really been the foundation for treatments, as previously discussed in the now moving into the neoadjuvant setting. In Checkmate 067, we now have 10-year data that demonstrates that nearly 50% of patients with metastatic melanoma are still alive. This was really the landmark and was FDA approved back in 2014. And I was like looking at a timeline because we know that we just really didn't have any breakthroughs. It was really only IL-2 until these checkpoint inhibitors and targeted therapies were developed, initially approved back in 2011. We've made progress. We've had a number of different approvals, with the most recent being TIL therapy. And so we have options that we can offer to patients, right? You can see we have several different immune checkpoint inhibitors. We have TIL, we have targeted therapies for patients with specific BRAF V600 mutations and TVEC. But why do we need more? And this is conversations that all of us in the field have to really push to others that look at that list and may say, well, melanoma, you guys have made such great progress. Why is it that we need to put more funding, more efforts into this space? And why do we need less toxic treatments? And that's because of exactly why probably all of you are here today. It's because of you. It's because of, your brothers, your daughter, your friends, your spouse. We still have patients that we're not curing their melanoma, and we need to do better. And so even though we've made significant progress with Ipi-Nivo, which is the landmark treatment that we have, we know nearly 50% of patients need second-line options because they're progressing. And so today we're just going to go through some of these trials that are ongoing and just some efforts that we hope are really going to change the field. So just briefly touching on immune therapy. So for historically, PD-1 was what I always tell patients, that's kind of the workhorse drug. This is the drug that we were giving in the neoadjuvant setting till we had data for Ipi-Nivo. We were giving in the adjuvant setting for stage 2 and stage 3 melanoma patients, and was the kind of primary mechanism of treatment that we would offer in the metastatic setting till we've had combination therapies that we know are effective. And so for patients that have progressed on just PD-1, Ipi-Nivo gives us a response rate of about 30%, so significant shrinkage of their disease. And that's really set the bar for what we expect and hope for what we consider at least an advance, but we really want it to be higher. And we know for patients that have progressed on either something like pembrolizumab or nivolumab by itself, maybe in combination with Ipi, and we try to use these newer LAG-3 combinations, the response rates just still aren't where we want them to be. So they're about 10 to 13%. So that's where TIL can come in place until we have data demonstrating objective response rate of 30%. We know some patients can be cured in the refractory setting, but we still need to do more. So I think Dr. Hernandez-Aya is going to discuss some of the PRAME molecules, but just wanted to lay the foundation of what are some of the novel targets and new areas that we're looking at. And so PRAME, I think, is certainly exciting. The way I think of it is this is a protein it's considered a cancer testis antigen. And so it's a protein that can be normal in certain settings in cells that are growing in the fetus, but really should be turned off. And some of you are probably familiar with PRAME PRAME testing on the primary tumor, and a lot of that work was done there at the Sylvester Cancer Center with Dr. Letsky, Dr. Hernandez-Aya, and Dr. Harbour, and really demonstrating the importance of PRAME as a prognostic tool in primary tumors. And we now know in patients in metastatic disease that when this is turned on, it can be very specific to cancer. And so this has been utilized in several different treatments that are ongoing in clinical trials. And I'll let Dr. Hernandez-Aya explain that a little further. We do have a number of other different IO options under investigation. IL-2, there's a number of different trials in this space. This is because we know IL-2 was effective. That was kind of the only effective therapy that we had for patients decades ago. The problem is it was highly toxic. And so these had the only treatment options that you had for patients were IL-2 based therapy that patients would generally have to be admitted to the ICU in case they needed blood pressure support because of high-grade fevers, fluid, causing significant drops in the blood pressure or swelling. And so there's a number of different trials coming back to that now and saying, okay, well, we know it can be effective, but the toxicity profile is too much. So how can we be maybe more selective with what we're activating with IL-2 to be effective? We have other cytokines or stimulatory molecules like IL-12. We have HSV encoded viral particles, other live viruses, anti-CCR8, TGF-beta. So really looking at all the other components of the immune system to say, what else can we activate? Moving into targeted therapy, which is where we'll spend a little bit more of our time today. Most patients are probably most familiar with BRAF mutations. This is standard of care testing that should be done on any melanoma. Certainly, stage 3 can be considered and done, and most definitely in the stage 4 setting, that's absolutely standard of care that patients should know what their BRAF testing is. So we know that about 40 to 50% of patients have a BRAF mutation, but also about 20% of patients have an NRAS mutation. And though this is important because NRAS mutations do lead to signaling through CRAF, kind of alternative pathways, instead of purely a BRAF mechanism. But this RAS-RAF-MEK-ERK pathway is where we see a number of different driver mutations for patients with melanoma. And this leads to that cell proliferation, survival differentiation. The way I explain it to patients is these are stoplights that are permanently turned on in a cancer, that instead of having that red, green, yellow appropriate signaling, they're just green, telling those cancer cells to grow. And so while we do have several FDA-approved treatments, vemurafenib, dabrafenib, and encorafenib, and then our MEK inhibitors, these are primarily for patients with BRAF V600 mutations, and these aren't effective for patients with NRAS or maybe atypical BRAF mutations. And so I take us back to, even for patients with BRAF V600 mutations, I think targeted therapies have gotten maybe I wouldn't say a negative connotation, but they've certainly been pushed to the side in the frontline setting because we've now had several studies, most prominently DREAMseq, demonstrating for patients with metastatic melanoma with a BRAF V600 mutation, we know the best chance of long-term survival is starting with immune therapy. But why is targeted therapy important? Well, if you go back to the initial phase 1 trial of dabrafenib, this is pretty impressive. So this is a waterfall plot, right? This is the percentage of shrinkage of tumor in patients with metastatic melanoma. This was such a game changer at the time, and really shows, I think, that targeted therapy can be very helpful and can still be a very good tool. We are just maybe more selective or more thoughtful about the sequencing and when to use these therapies. But certainly for patients that have maybe progressed on immune therapy, have had toxicities to immune therapy, maybe have autoimmune conditions, targeted therapies are still really a really critical piece of the treatment algorithm. And so while we know that most patients with BRAF V600 mutations benefit from IO followed by targeted therapy, the big question is, well, who else might benefit and what else can we target for patients with melanoma? So I think it's important to know what your mutation status is. And beyond BRAF, really patients should have DNA, potentially even RNA sequencing. This should be covered by insurance. There's a number of different companies, just to listed a couple here: Foundation, Tempus, Caris. A lot of academic centers have their own internal testing sequencer. And this can be tested on either tissue or blood. And this is an example of a report that this patient would have had IHC testing that was negative for BRAF, but it's important to know that this patient has an atypical BRAF mutation. And so can this open up other treatment options? These atypical BRAF mutations get classified into class 2 or 3. So class 1 are the classic BRAF mutations. So patients may ask, do I have a BRAF mutation? And that question usually is answered by, do you have a class 1 mutation? Because that's what targeted therapies that are FDA approved work on, or the V600. But class 2 and class 3 mutations, while far less common, are still important for trial options. And you can see here the difference in the mechanisms of action, that the class 2 BRAF mutations are dependent on dimer formation, and then class 3 mutations are dependent on RAS and dimer formation. And so just a little bit different mechanisms of action. When we've tried to use the treatments that are approved for patients with BRAF V600 mutation, for patients with NRAS mutant melanoma, using binimetinib, unfortunately, on the NEMO trial, this was a negative trial. When patients received either binimetinib versus chemotherapy, the median PFS was 2.8 months versus 1.5 months, and it didn't improve overall survival. And so this was not FDA approved, and is really was kind of the last phase 3 trial in this setting. But there's been a number of different trials ongoing, or that we have some early data on. So tovorafenib is a selective type 2 pan-RAF inhibitor. And so this was evaluated in patients with, it was a basket trial of patients with other alterations. But in patients with BRAF fusion melanoma, they had a response rate of 50%. And so certainly impressive, and that can be very meaningful for patients. Exorafenib is another selective type 2 pan-RAF inhibitor. This was evaluated both in monotherapy and exorafenib with binimetinib. And this combination demonstrated a 35% partial response in patients with NRAS mutant melanoma. And in patients with class 2 fusions, there were 2 patients with partial responses. So switching gears to CDKN2A. So while we are maybe most familiar with BRAF and NRAS mutations, CDKN2A is incredibly important. So we know that this is inactivated in 20 to 40% of patients with familial melanoma and 2% of patients with sporadic melanoma. So I pulled this from our NCCN guidelines, that certainly any patient that does have a family history of maybe multiple cutaneous melanomas, uveal melanoma, or some other cancers should have germline testing done, and likely in coordination with genetic counseling, just to determine if this might be a mutation that's potentially been inherited through a number of different family members. So what is CDKN2A? This is a heavy slide. Ultimately, this just shows it actually affects 2 completely different pathways, but both of these are important for cell cycle, for apoptosis, and for cell degradation. So what it does is essentially when you have CDKN2A mutations, this can cause these these abnormal cells to proliferate. And so it's important to know, because as we've better understood, exactly which patients may be benefiting from each therapies. One trial that looked at binimetinib in patients with NRAS mutant melanoma and added on ribociclib, which is a CDK4/6 inhibitor, they saw that in patients with the CDKN2A or CDK4 CCND1 alterations, that the objective response rate, the likelihood of tumor shrinkage, increased up to 30%. And then CDKN2A deletions are often found with MTAP loss. And there's several different PRMT5 inhibitors. So this is another oral pill therapy. And early data maybe demonstrated some benefit in these patients. And this is one patient that has been discussed in the literature that was treated with this PRMT5 inhibitor and had a partial response, and certainly significant improvement that you can see on imaging there. So a little bit more about PRMT5. So this is involved in regulation of a number of different cell functions. And so not only is this impactful maybe in cutaneous melanoma, but also in uveal melanoma. We know these patients can be affected by these splicing site mutations such as SF3B1. I know Dr. Letsky is going to discuss more about uveal melanoma later. But for another PRMT5 inhibitor for 10 patients that were evaluated with that splicing site mutation, 2 of those patients had a partial response and 4 patients had stable disease. So we're going to switch gears a little bit into antibody drug conjugates. So antibody drug conjugates, what these are is, the common statement that I may get from patients is, well, wait, chemo doesn't work. And you told me I was never going to get chemo. Well, what this is I like to think of antibody drug conjugates as a little bit more like paratroopers. It's high doses of chemotherapy going into the tumor. And so we think that this may be effective because that the doses of chemotherapy that we give that goes systemically for patients, chemotherapy isn't a good long-term treatment option for patients. But can we use these proteins that are on the surface of the cells to be able to target the chemotherapy at higher concentrations into the tumor? And so there's a number of different drugs in development for a molecule called HER3. This includes monoclonal antibody, bispecific, meaning just one handle versus 2, or these antibody drug conjugates. And one example is the HER3-DXd that's been under evaluation for patients with cutaneous or acral melanoma. And why is HER3 in particular an exciting target? Well, you can see here that there's been a lot of evaluation of this undergoing in breast cancer, and melanoma of the skin has similar expression of this target on the cell surface as breast cancer. And so I think just an area of interest there for patients with cutaneous melanoma. So there's a number of other different potential targets that are under evaluation. So Nectin-4, which is cell adhesion molecule, B7H3 and B7H4. These are immune checkpoints. ROR1, so this is a signaling molecule, and then tissue factor. And as we close out, I'll just demonstrate some data that was kind of hot off the press from ASCO this year. This was an antibody drug conjugate for anti-ROR2. And this was an abstract that was put out by the Sarah Cannon group in Denver, demonstrating that this molecule with a chemotherapy-based payload, that there were several patients with nice shrinkage and ongoing responses, including a patient with a complete response. So on the left is the patient's initial scans and images. And so you can see both responses in the liver and in the lungs. And this can be meaningful even to have a significant shrinkage for a patient, that maybe that patient can then get to surgery or get to radiation, even if we can't get a complete response. So I think certainly more to come in this space. So in conclusion, there's a number of different novel therapies under development. And the reason is because even though we've made a significant amount of progress, we still have unmet patient needs. And until we're curing every patient with melanoma, we have more work to do. There's both new and old targets that are under exploration, and maybe with more novel therapies and delivery mechanisms of how to get it there. Or in the case of IL-2, we're trying to navigate it so maybe it's less toxic, it's easier to give. Some of these trials are now just clinic, patients are just seen in the clinic and not even admitted, let alone in the ICU. We've come so far. And then we have new modalities such as these antibody drug conjugates in melanoma, and a number of different trials ongoing, and happy to answer more during our Q&A. So thank you for the opportunity to be here today, and for all of your attention on this Saturday morning.
Sorry, I was muted.
Fantastic.
Thank you, Dr. McKean, for bringing us such a hopeful perspective on the future of treatment for advanced melanomas. So I think we now are moving to our Q&A session. So I had several questions here. Let's start with the first one. So someone is asking, why does melanoma return? Is it because something is missing in surgery, or it's a new instance, or is it both? So who wants to take that? Dr. Chris, so is it because you
Yeah, it's
missed something
definitely
during
concerning.
surgery?
I hope not. Listen, surgery is there is robotic surgery, but it's not the way you want it to be. So I will definitely say that surgeons are human, and there could be always a chance that there could be a spot that's missing. But most commonly, it has to do more with the type of disease and the microscopic disease we can't see. So no surgeon goes in there thinking they're gonna, oh, I'm gonna just take out this portion and not remove that portion of the tumor. Sometimes there's microscopic disease, and one of the jobs of the surgeon is figuring out how much to take. So we can't take your entire skin. You can't live without that. We can't take every single last cell of your lymph node basin, because that would mean resecting some of the major blood vessels and nerves of your body to allow the functionality you want. So there's different components of potentially little microscopic cells left behind that you have to have left behind, otherwise you wouldn't have functionality of the organ. But simultaneously, melanoma's microscopic spread, we don't know sometimes when the little malignant melanoma cells will all of a sudden become more rapid and start growing cells. So it's oftentimes a combination of these two different factors.
And anyone else wants to chime in why this happens? I think the concept has changed over time, that being cancer in general, not just melanoma, being a localized disease, to being something that actually is more systemic from the get-go. You know, our ability to detect tumor cells and tumor cell DNA in the bloodstream sort of confirms that even early melanoma sometimes may have circulating cells in the bloodstream, and the immune system takes care of those. But for some reason, sometimes it doesn't. And that's when you see these recurrences. So let's go to the next question here. Can someone discuss the effect of any of fiber and sugar intake and the effectiveness of immunotherapy? Maybe Dr. McKean, you want to take that one?
Sure. Yeah. And I think this is a common question that comes up with patients, and one that I hope we continue to have more research on, right? Because we know that the medications that we give you in clinic, the treatments that we can provide, is just part of what we anticipate is affecting your emotional, physical health, right? But I think MD Anderson is and Dr. McQuaid has really been at the forefront of some of the data, looking at the impact of diet. So there was a study published probably about 5 years ago now, where they looked at patients that responded to immune therapy, and they had actually done surveys and looked at the diets of patients. And then they said, okay, the patients that responded to therapy versus didn't, is there anything that we can learn based on their diets? And what they found was that nothing earth-shattering there, I would say, but it was really that patients that responded to therapy were likely to have more likely to have diets that were high in fiber, fruits, vegetables, less red meat, no red meat, and less processed sugar. They also found that patients that were taking a probiotic were less likely to respond. And so I think that's something that I do advise to patients, that we think maybe the higher concentration of that oral probiotic may cause overgrowth in the GI tract. And then it was at ASCO this last year that they actually did a randomized trial looking at fiber intake. And it was high fiber. So they looked at, I believe it was 50 grams versus 20 grams of fiber per day. So even the low fiber diet, that's quite a bit of fiber. But what they saw was that doubled the response rate to immune therapy. So I think that takeaway isn't that everybody should be taking a ton of fiber supplements, but I do think there is an importance of the diet and the food we eat. It's not something that can necessarily change overnight. So this is advice that I give patients that have had early stage melanoma, like stage 3, saying, hey, it is important to have a healthy diet moving forward, in addition to patients with stage 4 disease. So I think we're certainly learning more, but maybe those are some takeaways. So Dr. Lutsky, I don't know if you have any other thoughts or any other
No, thank you.
studies that you've
I
seen.
totally agree. We're actually in the process of embarking on a diet modification study here because, as you said, I think there's overwhelming evidence that diet is really important on how
I was
patients
just
do.
I was going to just add on one other component is healthy eating and exercise in general, maintaining your weight will allow for whatever treatments we give you to be better. Will respond better to them and heal from them better. So it's a known risk factor for complications from surgery is obesity in almost every type of surgery. So one of the best things you could do is maintaining your weight. Nobody wants to develop cancer, but in the unfortunate time that it does happen to you, if your body is fit for surgery or immunotherapy or whatever it needs, you might as well optimize all that you can do so that the treatment you receive can be best tolerated and be as effective as possible.
Thank you. So let's see, we have another question. Do we know what turns off our immune system and allows cancer to grow? I guess I wish we knew. We're still trying to find out that answer. That obviously is an important question. Why would I think this maybe for you, Dr. Crystal, why would anyone wait to start immunotherapy after surgery since neoadjuvant therapy seems to be so much more effective?
Great. One of the key reasons is that not everyone needs it, and you have to balance the benefit of the immunotherapy with the side effect profile. So we didn't go too much into this, but the immunotherapies can be toxic, and there are some studies where even one dose of immunotherapy unfortunately did result in death. So the patients that we do use immunotherapy in are the ones with a higher burden of disease, so that it could be most effective. However, there are ongoing trials looking at backing down on the stages of who we offer immunotherapy to. Simultaneously, when the melanoma is contained and a smaller depth of disease, a lower depth of disease, surgery is still the mainstay for treatment because a surgery that can be performed in the outpatient setting, only 1 day of a treatment and then a little bit of recovery after, is a very effective tool at curing your melanoma. So most people prefer a 1 day of treatment as comparison to ongoing subsequent treatments where the side effect profiles may be temporary, but also may be permanent.
Okay, thank you. I have one, I think, Dr. Tang, maybe you can help us with this one. Someone just completed treatment for a stage 1B melanoma. This person is asking whether they will be always at a higher risk for melanoma and other skin cancers.
Yes, so the number one risk factor for melanoma is having a previous melanoma, and that's not to worry you that it's your original melanoma coming back, but you have a much higher risk of developing another melanoma at a different site, and that's just a surrogate, meaning marker of you've had a lot of sun damage or you either have genetic, predisposition for having melanoma. So I don't want to worry you that, the risk is not always in the primary site, but you do have increased risk for developing a second cancer, whether it's melanoma or non-melanoma skin cancer.
So may I ask you, what are the current recommendations in terms of monitoring from the dermatologic standpoint for patients who have had a melanoma?
So there's no great consensus still, but I think in general, for the most part, we monitor for a melanoma diagnosis. We typically follow patients every 3 months for the first year, and then we taper to every 6 months for the next 3 to 5 years.
Dr. McKean, how close are we on vaccines for melanoma?
Well, I'd like to say we're as close as we've ever been, maybe. For any of you following the field, there's been cancer vaccines under development for decades, to different peptides, and just different kind of off-the-shelf markers. But I think probably the most promise right now, and we're awaiting results on in the stage 3 setting, we're awaiting results on the Merck Moderna personalized or individualized neoantigen therapy, the mRNA 4157. And so this is for patients. It's in the adjuvant setting, so it is patients that had high risk stage 3 disease that did not receive neoadjuvant treatment. But these patients had a personalized cancer vaccine, individualized neoantigen therapy. Basically, the tumor was sent off. They looked at and predicted which 32 proteins do we think are most specific to this cancer that the immune system might be most likely to recognize. And those patients received a personalized therapy. So the results from the randomized phase 2 look good. So there's now been a large phase 3 that we're awaiting results on. And then I think there's also been a couple companies with off-the-shelf vaccines in the stage 4 setting. I think the earlier settings certainly seem a little bit more promising, right? Before that, cancer's had a chance to kind of grow a number of different places and maybe look differently and hide from the immune system differently. But I think there's really been some exciting progress, and would love if this is, an option we can offer to patients in the near future.
Thank you. I think this is another one for you, Dr. McKean. Are there any exciting developments in research in mucosal melanoma?
Yeah, it almost seems like, unfortunately, mucosal melanoma has actually been the hardest to make progress in. It certainly is one of the more rare types of melanoma, but I think trials are getting better at trying to incorporate patients with mucosal melanoma. So I briefly discussed the PRAME targeting therapies. One trial with a PRAME targeting bispecific for patients with cutaneous melanoma is enrolling a number of patients with mucosal melanoma. And I think that's how a lot of trials are doing it and saying, okay, well, even if we aren't doing specific trials, can we enroll a number of patients with mucosal melanoma to be able to understand, does this look beneficial or not? I think the patients with mucosal melanoma tend to have these atypical BRAF mutations, and so that's been an important area of progress and another reason to have that molecular profiling done, because we can see some of these atypical BRAF mutations, and those are trials that are ongoing. And then there are some trials targeting the KIT mutations that we know we can see for patients with mucosal melanoma. So I think there's been progress, not as much progress as we'd like, and still remains a big area of need.
Thank you. Let's see, we have one more question, actually. Dr. McKean, again, what do you see as the option which holds the most promise in the treatment of advanced melanoma?
Oh, that's so hard. I mean, I think the good thing is that there's a number of trials that are kind of moving through and getting into the phase 3 setting. I think some of them are yet to be discussed with some of the Amatics trials, some of the cellular therapy trials that were very fortunate to maybe making progress there. So I wouldn't say there's any one treatment, because I think, I think the likelihood of us finding another anti-PD-1 that most patients can benefit from is going to be hard, and so that's why I think each of these treatments that we're hopefully having some incremental benefit with the targeted therapy options and different profiling options. Cellular therapy, that's some of those trials, the next generation TIL, the Omatics. I think that there's certainly a lot of excitement there, but I think there's not every patient that's the right treatment option for them either. And so that's why I think it is nice to see a number of these different trials advancing and moving forward and enrolling patients with melanoma.
Thank you.
And I'll maybe comment on that as well. I think we have, as a field, we have to move towards trying to incorporate biomarkers to try to find, what therapy can work specifically for that particular patient. I think, and that's where most of the trials are trying to now start incorporating, specific proteins to target and receptors to engineer, towards a specific target. So I don't think we can talk about what is maybe the best out there. I think it will be for that particular patient with what we know about the melanoma and the patient, what could be the best clinical trial or the best option.
Thank you. So in the last couple of minutes that we still have before the break, I just wanted to maybe pick Dr. Tang's brain here. We as medical oncologists, sometimes see patients coming in to the clinic with a gene expression profile test that says, well, this patient may not need a sentinel lymph node biopsy, when by other means there is an indication for a sentinel lymph node biopsy, or that a patient that is staged as a stage 1A comes with one of these tests that says they're very high risk of recurrence. And it is difficult for us to know, because with a stage 1A or 1B patient, we would not be doing imaging on these patients. If someone has a very high rate of recurrence, we may want to do imaging. So it creates a lot of issues. And the Castle Bio is now actually embarking on a randomized trial or a prospective trial of this test that I think has been coming for a long time. We have a lot of data that's not prospective and retrospective. And Dr. Tang, I know you are involved in that. Can you tell us about that? Because I think until we have prospective data, we should probably not be acting on the results of these tests. I want to hear Dr. McKean's and Dr. Hernandez's opinions on that as well.
That's a great question. So what Dr. Lutsky is alluding to, so there are these commercial tests called gene expression profiles, where they send your biopsy assessment to these proprietary companies, and they run it against their panel of genes that they have concluded are relevant in predicting risk for you. So as Dr. Lutsky mentioned, all of these are based on retrospective studies. So, data that has been collected in the past, but not an ongoing setting. And also it's some of the flaws there, it's only based on your tumor. So there's a lot of other additional information from the patient characteristics that can aid in predicting risk as well. So that's some of the flaws in using the gene expression profile exclusively. There are commercially available ones. There's a company that has an assay for both melanoma and for squamous cell carcinoma. And there's another company where they attempt to include some of those patient characteristics. But at this point, it does not, it's not in any staging system per se. They have small footnotes in NCCN, but that hasn't been incorporating in any staging system per se to supplant sentinel lymph node biopsy, because it can't, that additional information is useful for adjuvant therapy in certain settings. So for higher risk melanomas, we still don't know, where to use it. And then there's the risk of these, for lower stages of overtreating someone as well, because then we're, imaging people every, 6 months and subjecting patients to radiation from the CT scans. So I think keep your eye, out. Will be prospective studies at least from the squamous cell standpoint, but I believe in the melanoma as well.
Dr. McKean, what's your opinion on that?
Yeah, I think it's been great to see technology in this space, right? I mean, I think the using depth only as a risk characteristic, it is nice to see sequencing making advances in early stage disease. But I agree with Dr. Tang and kind of how we interpret it at our center. It's helpful, I think, to reemphasize to patients the importance of, yes, you were, hopefully cured with surgery, but you need to follow dermatology carefully. These are the signs to watch out for. We aren't using it to guide our sentinel node decision making. Have there been a patient or two that's elderly that didn't want it, that we used it to support their decision, but really we're kind of treating ourselves more than anything, because that patient had said that they had not wanted that procedure. But otherwise, just using it for patients that have had it as another piece of information to help them understand their risk, but has not changed our surgical management at our center.
One comment I'd like to also make on when we're trying to decide who needs sentinel node, I am in agreement with the group regarding use of genomic expression profiling. I'm relying a little bit more heavily on the traditional factors to determine who needs a sentinel node. So the depth and ulceration, because those have been consistently proven to help guide us to which patients typically have microscopic disease present in the lymph nodes. In addition, as a supplement that I've been using, and more data is going to be coming out, I'm sure, in the future regarding this, there's a terrific risk calculator developed by the Australian group looking at the risk of melanoma involvement in the sentinel lymph node biopsies. And that's a completely free test that we can look at to use. It's just an online tool to look and see what each patient's risk is for sentinel lymph node involvement. Now, it's not perfect, of course, but it's helpful and it's free, because one of the side effects of this genomic expression profile is it's expensive. Who's going to pay for it and for what benefit? So I think it's an important consideration as well.
Thank you. We did great timing today. Thank you to all of you for keeping your talk on right on track. So I think we have a 10-minute break now, and we'll be back at 10:45 with Dr. Hernandez, and then I will talk about uveal melanoma. See you in 10. Hello, everyone. We're back for the second part of our symposium today. And our first speaker of this portion is Dr. Leonor Hernandez Aya. Dr. Hernandez Aya is going to talk about the very exciting field of cell therapy and how it has made its way into the treatment of melanoma. Dr. Hernandez.
Okay, thank you. Thank you, Dr. Lutsky. Can you see my screen well?
Not yet.
Yeah, okay, very good. So good morning.
We don't see it.
Oh,
I don't see it at least. Yeah.
let me just make sure.
No, it's not up yet.
Okay, let's do this again.
Got it.
How about now? Yes, so good morning, everyone. My name is Dr. Leo Hernandez Aya. I'm a medical oncologist at the University of Miami. Thank you to the AIM at Melanoma Foundation and to the organizers for inviting me to speak with you today. So I will be talking about cell therapy, which is a very exciting new treatment options for patients with melanoma. And my goal is to explain to you and your families what this therapy is, how it works, and where we are today. So this is the outline of the talk. So we'll talk about what cell therapy is, how tumor-infiltrating lymphocytes or TIL therapy works, who might be a candidate for TIL therapy, what the benefits, risks, and what to expect when someone is going through this therapy, and also recent advances and clinical trials in this field. So let's talk a little bit about what cell therapy is, and I will start by a brief history of how we got to this point. So the idea of using the immune system to fight cancer is actually not new. Over 100 years ago, a physician named William Coley, which he's often called the father of immunotherapy. He used mixtures of bacteria known as the Coley's toxin to try to stimulate the immune system to attack cancer. And he treated many patients, mainly with sarcomas, injecting this mix of bacteria. And there were very encouraging and positive results. And this basically planted the seed for what we would later become the field of cancer immunotherapy. Then in the 1970s and 1980s, researchers learned how to grow immune cells in the lab. And I think that's when the field really started to make more progress, because now we could actually test how the immune cells can recognize cancer cells and what the mechanisms are to get rid of them. And one of the true pioneers is Dr. Steven Rosenberg at the NCI. He developed the concept of adoptive cell therapy, which is basically taking the patient's own immune cells, expanding them in large numbers, and giving them back to fight cancer. And his early work with tumor-infiltrating lymphocytes, you can see that this was a publication from the 1980s, mentioned TILs, tumor-infiltrating lymphocytes, that showed very promising responses in melanoma patients. And this kind of laid the groundwork for the therapies that we have today. And then later in the 2000s and early 2020s, then the new treatments that we are using with immune checkpoint inhibitors, and now we have a renewed interest in TIL therapy, because now we can do it in more centers, not just at the NCI, like where Dr. Rosenberg was doing his work. So And these are some examples of patients that Dr. Rosenberg treated back in the 1990s with melanoma. These are just pictures that are, this is the liver of a patient with melanoma with multiple metastases that unfortunately at that point there was really no effective therapy options. And after getting TIL therapy, what we call the first generation TIL, there were significant and durable responses, eliminating basically the tumors from the liver, and in this case, from the lung. So there was, again, this very remarkable interest in this form of immunotherapy. So when we talk about adoptive immunotherapy or cell therapy, these are the key principles. So what we're trying to do is we're using the immune cells, your immune cells, or each patient's immune cells, that they are already attacking the cancer. They're specific, and we know that they can kill tumor cells. So we take them, and we know that they are reactive. So they're basically taken and then activated. We cultivate them to increase the numbers, and then they are transferred back to the patient. So one of the problems why we think that a lot of, several of our treatments don't work very well, like checkpoint inhibitors or other form of immunotherapies, is because we may not have, or that particular patient may not have enough quantity of the immune cells to do the job. So this form of therapy brings the solution to basically grow the cells in vitro in the lab, and then activate them and then transfer them back to the patient. So it's given the solution to that problem of that we have seen. This basically means that we can collect or engineer immune cells and give them back to the patient. So that's the goal. And when we do this, we can boost the number and activity of these cancer fighting cells. And I included here a figure of what all the cells that could be infiltrating what we call the tumor microenvironment. So there are multiple cells that are actually living and infiltrating the tumor that when we take them out, we can expand the ones that are effective to kill cancer cells and then give them back to the patient. So there are two main families, or I like to think about two main types of therapy. One is called autologous T-cell therapy, which is using your own cells, which is what we're doing in melanoma TIL therapy. And then allogeneic type of cell therapy, which is using donor cells, so cells from a different patient. This is in research in melanoma. So we're gonna focus the talk today about autologous cell therapy, which is using your own cells to try to fight the cancer. And the common types that you may hear about TIL therapy, engineered T-cell receptor therapies, and CAR T cells. And we're going to talk a little bit about those and the ones that we use in melanoma. So now let's dive in to talk more in detail about TIL therapy, or tumor infiltrating lymphocytes. And these are immune cells that are already in the, so yes, these are immune cells that, as I said, are already inside your tumor and trying to fight the cancer. So in the lab, we try to expand them to then give them back to you in billions in order to help fight the cancer. So this is the therapy step by step, and there are several key steps in this process, and that's why this is it's a team effort, with the patients, with or surgeons or cell therapy specialists. And so this requires infrastructure to be able to do all this. But basically, we start with the patient here with removing part of the tumor. So a surgeon or an interventional radiologist will remove a small piece of tumor. It's about 1.5 centimeters or a little more if we can. But this piece of tumor will provide us with the T cells that already recognize the cancer. And then those T cells are grown in a specialized clean lab, and then they are expanded over several weeks. So this process can take about 4 or 5 weeks. And then there will be a lot of quality checks to make sure that the product is safe, and then to give back to the patient. And then once we know that the product is ready, then we need to prepare the patient for the infusion. And to do that, we admit the patients to the hospital. And then before we give back the infusion of the cells, we have to do a short course of what we call low-dose chemotherapy. It's basically 7 days of chemotherapy. That what it does is preparing the body, opening space in the system to then be able to receive billions of this very active fighting T cells. So this chemotherapy reduces the competing immune cells in your body, and then helps the new TILs to grow and engraft in the system. And then once we complete the chemotherapy part, is the infusion day, and that's when the TILs are given back to the patient. And sometimes it's 1 or more bags, but during that process, the patient is admitted, is being closely monitored by the care team. And then after that is what we, the after infusion portion of the treatment is when we give supportive medicines, and we give immune stimulating treatments like interleukin-2 that are basically given to help the T cells work better. So during that time, the patients are monitored in the hospital, and then we once they're ready to go home, then they're discharged, and after that we monitor them in clinic. So in summary, this is a one-time therapy. We do this once, and this involves removing the tumor cells, growing those immune soldiers in the lab, and then giving them back to you in much greater numbers so they can fight the cancer. So that's the general process and about TIL therapy. And I want to talk specifically about the treatment that was recently approved for patients with melanoma. So you may see this name out there. So it's the Iovance is the company that is manufacturing the TIL therapy. And the product is called lifileucel. It's also known by the brand name of Amtagvi. But this is their first-in-class autologous TIL therapy. And now we have the process that I explained to you before. So the difference that Iovance made was to they were able to basically streamline the process and learn from all that success from the NCI processes, but then they developed this centralized process that is now scalable and can be used on multiple centers. So we have to they will manufacture the cells for us, and then ship them back to the patient. So the results from the clinical trials that basically led to the approval of Amtagvi or lifileucel are shown here. So this trial enrolled patients with advanced melanoma who had already received multiple lines of therapy, including checkpoint inhibitors and targeted therapy. So these were patients that had no really good options of therapy, maybe palliative chemotherapy as an option, and they give them this treatment with the TIL therapy. And here you can see what we call a waterfall plot, where each of these bars is a patient tumor. So when the bar goes down, it's because the tumor is decreasing in size from the baseline. So you can see that the patients that were enrolled in this trial, a large proportion of those patients actually had a reduction in the tumor burden. And specifically, we saw objective responses in 31.4% of patients, but then a large proportion of them had some form of tumor burden reduction, which is, again, remarkable for patients that don't have really, any other options. And even some patients, down here had complete responses, which means that the tumors completely went away with this therapy. So among those patients that had a response, the median duration of response was over 3 years, and some responses are still ongoing. So in terms of side effects, I think it's important to realize that the reason why we give this treatment in the hospital and the reason why we have to admit the patients to the hospital is because most of the side effects, there could be high grade or severe side effects associated with TIL therapy. And those side effects typically happen in the first 2 to 4 weeks after this treatment. So those first, and as you can see here is, small bars here representing the patient, the number of patients that have, or the number of adverse events that we're seeing. And as you can see, most side effects happen within the first 2 weeks while the patients are admitted, but we have them closely monitored. And those side effects are mostly related to the chemotherapy that the patients have to receive, and also related to the supportive IL-2 therapy that they have to get to help those cells. And then once they are discharged, maybe after 3 or 4 weeks, normally 2-3 weeks, they may stay in the hospital. And then the side effects after that, this is month 1, month 2, month 3, then we don't see really more side effects. So this time here is critical, and that's why we admit the patients to the hospital. And then we're seeing the median overall survival was 17.4 months, but about 20% of patients were still alive at 5 years after they received this therapy. So this is just a summary of the trial. It enrolled about 153 patients, and this is the numbers of what I showed you here. So the main side effects, like I was explaining, are related. Those side effects related to the chemotherapy, the low blood counts, like low platelets or anemia. But we can see infections from febrile neutropenia, and we can see side effects from the IL-2, like capillary leak syndrome, that we have to be very careful about, because again, there could be severe and even lethal side effects. So we monitor those patients very closely, and this is an example of a patient that received lifileucel in the clinical trial. And this patient had this tumor on the side of the right of the axilla, and then had a good response. This is a tumor in the lung, also responding to the treatment, pre-TIL, and then 3 months after therapy. And as I said, some responses can be durable. The key takeaways from this therapy, it's in summary, this is a ready-to-infuse autologous TIL therapy. So it's made from your own tumor-infiltrating lymphocytes, and it's a one-time therapy. It was developed by this company called Iovance. So we have to, we collaborate with them in order to manufacture this treatments for our patients. And then in February of last year, the FDA granted accelerated approval for this therapy. And now there's also a clinical trial evaluating lifileucel in the frontline setting. So basically, in patients that are newly diagnosed with metastatic melanoma. So I included this slide to talk a little bit about the timeline and logistics. So like I was saying, typically this is a one-time therapy, but it involves a lot of planning, a lot of coordination with multiple teams. So we expect to, after the tumor is collected, it can take 1 to 5 weeks to grow the TILs, and then the treatment in the hospital that can take 2 or 3 weeks, followed by recovery and the frequent follow-up. So it's very important that if you're considering this trial, or your doctors are discussing this option, for you, that we have to talk about arranging support and sometimes local housing if you're traveling. Discuss work, school, and family schedules for that time. So who might be a candidate for TIL? So again, like I said, that trial that led to the approval of this therapy enrolled patients that had metastatic disease. So this is for patients that have already a melanoma that has spread to other sites of the body or returned after standard therapies. So the patients have to have adequate organ function because, as we said, it involves hospitalization, chemotherapy, and treatments that can have effects on the cardiovascular and pulmonary system. So we have to, do some evaluation to make sure that a specific patient is a candidate. Also, we need to make sure that the tumor site can be safely removed for the manufacturing process. And, who may not be eligible? I will say patients that have severe or uncontrolled medical conditions, or, inability to tolerate chemotherapy and supportive medications like IL-2. Or patients that maybe don't have a tumor site that can be safely sampled. So your oncology team will have to discuss all these details and other alternatives that, like we discussed, there are new trials that are trying to investigate other forms to be more tolerable for our patients. I just gonna skip this part. So one of the most common questions is, where can I get this treatment, or where can a patient receive this treatment? And lifileucel is only offered at certain authorized treatment centers across the country. So these centers, again, have the staff, the labs, all the infrastructure that is needed to safely administer this TIL therapy. So there is this online resource on the website of TACV, where patients and caregivers can search for the nearest authorized treatment center. And there are, this changes every, week, month. So it's important to be updating. And then I'd like to highlight that at the University of Miami is currently the only authorized center in South Florida. So this means that patients here in the Miami area don't need to travel out of state to access this therapy. We can provide it right here at Sylvester. So let's talk a little bit about engineered T-cell receptor therapies, because this is another exciting type of cell therapy. It's still undergoing, it's in research in clinical trials, but the basic idea of autologous or engineered autologous cell therapy is that instead of using the lymphocytes that are infiltrating the tumor, what we do with this is we use the T cells, we get them from the blood, so we don't extract them from the tumor, we just get them from the blood, the T cells that are circulating, and then we genetically engineer them with a special receptor that is called a T cell receptor. And this T cell receptor is designed to recognize a very specific protein in the cancer cell. So, and this is important because sometimes, cancer can hide from the immune system. And by giving a T cell that it has an engineered receptor that is very potent to find the specific target in the cell, is like giving those immune cells like a new pair of glasses to see the cancer better. So this makes the T cells more powerful, precise, and they can recognize the cancer cells that they may have missed before. So this is still, as I said, in clinical trials for melanoma and other solid tumors, but there's a lot of progress. And basically, is the process. What is different is that we don't have to do surgery to remove part of the tumor. So what we do is we collect the T cells from the bloodstream. We do a process called leukapheresis, so the white blood cells can be collected, and then they're sent to the lab, and they can be activated, and then they can go through this process of genetic engineering for this very specific T cell receptor, and then those cells are go through a process of proliferation, and then we can give them back to the patient for treatment. So thinking about this, obviously we have to think about what is a good target, because we are making these genetic modifications to the lymphocyte to try to make it stronger. So a good immune target for the T cell receptor is basically a target that has to be specific to tumors, but not in normal cells. So we can maybe decrease the risk of target toxicity. It has to be expressed in high enough quantity to effectively eradicate the tumor, and it has to be expressed in a variety of cancers to be more applicable. So PRAME, for example, is a very promising target in cancer immunotherapy. So, for example, in melanoma, it's expressed in over 95% of patients, and that's why this protein has been subject of clinical trials trying to develop very specific receptors to PRAME. And one example is this platform by a company called Inmatix that we have here at the University of Miami that is a T cell receptor targeting PRAME. So we have been participating in these clinical trials, and this is basically what I just explained. But what was very promising is the responses that we have seen with this therapy. So as you can see here, most of the patients, or a large proportion of patients that received this cell therapy, had reduction in the tumors, and so close to 55% of patients with melanoma that have progressed on multiple therapies received this treatment and had a very good response. So because of this, we are participating in a large trial to try to get this treatment to be hopefully approved, and we'll see if it's better than what we currently have available. So just to wrap up, I want to briefly look ahead and talk about what is on the horizon. But this field is moving fast, so we're trying to use combination therapies. So combine, for example, checkpoint inhibitors with TILs, and then also generate the next generation of TILs with gene editing or new targets for engineered T cells. Look for biomarkers to try to see which patients can benefit the most, and then maybe make them more tolerable. And there are different trials that are basically looking into that. And this is one trial that it's available and that is very exciting. I don't have time to talk about details for this, but this is, again, participating in clinical trials is important. So I think here I just, this is my last slide with some tips for patients and caregivers. So talk about your patient, talk about with your doctors about this treatment and see if you might be a candidate. But there are some things that you can, are in your hands to be a candidate for this. So I just included that there. And I think I'm gonna end up here because I'm running out of time, but I can answer any questions that you may have.
Okay, thank you, Dr. Hernandez. We will have another question answer session after my presentation today. So let me make sure you guys can see. Okay. Are you able to see the slides?
Yeah. Yes.
Okay.
Yeah.
All right. So my job today is talk about uveal melanoma. Uveal melanoma is a rare disease. It's a disease for which the prognosis has been very dim, but we have made substantial progress in treating this disease over the last several years. And so I'm going to review some of that data, and these are my disclosures. And this is a slide that Dr. Orlov presented in ASCO in 2019, and I modified a little bit because I had to add some recent information. But essentially, it shows that uveal melanoma and cutaneous melanoma are not the same disease. They come from the same cell type, the melanocyte, but they're different in many, many ways. Beginning with the incidence, uveal melanoma is a rare disease, is about 4% of all melanomas. We don't know what causes uveal melanoma. We have some clues, but we do know what causes cutaneous melanoma, which is mostly UV radiation. The mutation profile is very different in uveal melanoma than it is from cutaneous melanoma, really explaining why these are two different diseases. You manage these diseases differently. Cutaneous melanoma is managed by surgery and maybe sentinel lymph node biopsy. Uveal melanoma is managed by local treatments of the primary tumor. The way you figure out who is at high risk is different. In cutaneous melanoma, we look at the stage, we look at lymph node involvement, we look at some gene profiles. In uveal melanoma, the best way to determine prognosis is a gene profile and the staging system. The pattern of metastasis of presentation is different. Uveal melanoma, 50% of the time presents with metastasis only on the liver, and up to 80% of patients will have metastasis in the liver and other areas. The treatment is really the most marked difference. We have a lot of treatments, as you have seen this morning, for cutaneous melanoma, but there's only one approved treatment, which was just recently approved for a specific subset of patients with uveal melanoma, the patients that have HLA-A201 immune type, and that treatment is the bempafusp, and we're going to be talking about that, of course, as it goes. So uveal melanoma can occur in different parts of the eye. The most common part is in the choroid, which I'm not sure you're seeing my arrow, but if you are, I'm pointing to where the choroid is. Another is melanoma of the ciliary body, which is here, and the other is melanoma, uveal melanoma of the iris. So very briefly, what are the treatment options for the primary tumor? In the past, these patients were treated with enucleation. At least in the United States, we rarely do enucleations. Now, we only do that when the tumor is invading the orbit, when the vision is irreversibly lost. In those cases, sometimes patients undergo enucleation. We mostly use plaque brachytherapy, and you see an example here of plaque brachytherapy. It's a plaque that has radioactive material, and you leave that in usually for 3 days while the patient is in the hospital. You take it out after 3 days, and patients go home, and this has a very, very good control rate of the primary tumor. Rarely, we're beginning to use proton beam radiotherapy more in centers that have proton beam available. Local resections are not very common. And for patients that have very, very small tumors, sometimes laser hyperthermia is used. So for patients that present with disease in the liver only or mostly in the liver, there are several ways that we can treat these patients. We can do what's called hepatic-directed therapy. There are some ablative forms of hepatic-directed therapies, including surgery, including killing the tumor with radiofrequency ablation, which you put a probe in the tumor, and you have these radiofrequency waves applied to the tumor. You can also cook the tumor with microwave ablation or freeze the tumor with cryoablation. And there is stereotactic ablative radiation, which is a form of localized radiation therapy that can be given to the tumors. There are also other approaches in which you use the circulation in the liver to kill these tumors. You can embolize the tumor, meaning you get into the hepatic artery and you throw little emboli there that will clog the tumor, clog the circulation. We can do just that, or you can do chemotherapy administered at the same time, or you can send microscopic radioactive spheres into the tumor that we call CERT or Y90, and that can also treat those tumors that are being embolized. Or how it's done in, for example, Philadelphia, they do they do embolization with immunotherapy drugs given into the tumor as well. And there are also newer approaches that are not embolic. There's hepatic arterial perfusion and isolated hepatic perfusion. And these are procedures in which the circulation of the liver is cut off from the systemic circulation, and high doses of chemotherapy are given to the liver and stay mostly in the liver. And these have been effective in decreasing the tumor burden in the liver. The problem with that is that these have been open approaches, so it's big surgery. More recently, percutaneous hepatic perfusion given by special catheter called heptatozac, has been approved in the United States and has been used more frequently to treat these patients. So there's some novel liver-directed approaches. There are combinations of liver-directed therapy. For example, percutaneous perfusion is being tested with a combination of ipilimumab and nivolumab. We are doing a trial here at Sylvester using radioembolization followed by tebentafusp in patients that can receive tebentafusp. There are trials looking at stereotactic radiation in nivo-rela. This is a study that we were one of the centers using a drug that stimulates the innate immune system, giving directly into the liver in combination with immunotherapy. There are also tumor treating fields, which is a technique that has been approved for brain tumors and now being tested in uveal melanoma. And there's histotripsy that I'm going to talk a little bit about because I get a lot of questions from patients about histotripsy, which is a relatively new liver-directed modality. And here you see what histotripsy is. It's really a very focused amount of ultrasound waves that are given directly to the liver tumors, and it's non-invasive. You can see here that the ultrasound really creates this cone, and with this cone you can target the tumor, and what happens is the tumor becomes like this kind of bubbly, and it dies. And the thing is that there really isn't a whole lot of data of histotripsy, and still a procedure that we really are waiting for a lot more data before using it more extensively. There aren't too many centers in the US that are doing this, but there are some. And here is just show that it is non-invasive. That seems to be the main advantage. Patients lying down, this machine comes and creates that cone of ultrasound waves. So when the disease is more extensive, we have to think about systemic options, chemotherapy, targeted therapy, immunotherapy, and cell therapy. I'm going to spend 2 seconds on chemotherapy. Basically, all these studies, what they showed is that chemotherapy, it very, very rarely or never works in uveal melanoma. So most of the time, we don't even bring that up as a legitimate option for patients. So I'm going to move on now to targeted therapy. So targeted therapy is therapy that's targeted to the molecular pathway that leads to the stimulation of the tumors. And this is the molecular pathway for uveal melanoma. These are the G proteins here, and it goes this way to the protein kinase C and to the RAF/MEK/ERK pathway. This is another way in which that these cells can be stimulating, going to the PI3K pathway, AKT, mTOR. And this is a non-traditional pathway through YAP that can activate the tumor cells. What I really want to point out here is that we have tried, we as a scientific community have tried over the years to intervene in a lot of these critical points on the pathway. And as you can see, the results have not been impressive. We have not seen major responses. We have not seen prolongation of survival, but there is hope. Very recently, this drug that works on protein kinase C called darovasertib has shown the potentially a very broad impact in the treatment of uveal melanoma, particularly when it is combined with another drug called crizotinib. Crizotinib works on this part of the pathway, on MET, not this part of the pathway, it's MET. And when these two drugs are combined, we see really remarkable responses in metastatic uveal melanoma. And this is the data from the phase 1 trial. And you can see that there were 30% of the patients had a partial response. 60% of the patients had stabilization of the disease. Only 11% of the patients progressed. And in these patients, there was shrinkage of the tumor in 92% of patients. So this is quite impressive. And Dr. McKean actually was the person that presented these data in an international meeting a couple of years ago. And this data led to this clinical trial in which patients that have to be HLA-A201 negative. And the reason for that is that there is an approved first-line trial for HLA-A201 positive patients. And this trial is, this initial phase here is completed. So the trial is now at this point in which we have determined a dose for the combination of darovasertib and crizotinib, and this is being compared in a 2-to-1 randomization to an investigator's choice arm. 2-to-1 meaning twice as many patients are randomized to this arm as compared to investigator's choice. And investigator's choice is not any choice, it's those specific choices there. So the trial is ongoing. Patients are treated with this oral medications until disease progression or until they develop toxicity that's not acceptable. There is also some data using darovasertib as a single drug before patients got their definitive treatment. It actually, a small trial in Australia has shown that there was shrinkage of the tumor. And based on that, this clinical trial is also ongoing. It's neoadjuvant treatment with darovasertib, and for two groups of patients. One is a group of patients that is going to receive plaque brachytherapy, but will require a lot of radiation. And the question here is whether you can shrink the tumor enough before the plaque brachytherapy that the field of the radiation will be modified and the vision loss caused by radiation may be reduced. The other group is patients that have very large tumors that will require enucleation, but they still have usable vision. And the question here is whether you can shrink this tumor enough that they may not require enucleation. You can save the eye and save the vision and be able to treat these patients with, say, plaque brachytherapy rather than enucleation. So this is ongoing, and we're looking forward to the results of those trials that can potentially impact the practice. There are other targeted therapy, in fact, too many to come. I mean, this is sort of a miracle because, 10 years ago, I can tell you that you really had to look very, very extensively to find one trial to treat metastatic uveal melanoma. Now we have all sorts of targeted therapies being used. And as I said, this is too extensive to go into a lot of detail. The point here is there seems to be now a lot of experimental options for these patients. Let's talk about checkpoint inhibitors, immunotherapy. There are no data comparing a single checkpoint inhibitor with combination checkpoint inhibitors. So we have here the data for monotherapy, just things like nivolumab or pembrolizumab, and you can see the response rates here are in the single digits, with this one exception here. And the median progression-free survival and the overall survival are really not very different from what we see without these treatments. And then you get to combination, and we're talking here mostly about ipilimumab and nivolumab, and you see a slight uptick here in the response rates, maybe low 2 digits. However, you don't really see a major corresponding improvement in the median progression-free survival, and maybe a slightly improved survival. So essentially, there's no prospective comparative data here. And if you're going to use immunotherapy in patients who can tolerate it, we consider combination. Patients who cannot, single agent is not a bad idea. But we do now have an approved treatment for patients who are HLA-A201 positive. And why is that? It's because the target of this new treatment is a protein called GP100, and GP100 is a protein that is only appropriately expressed when the patient has an HLA-A201 phenotype. If the patient does not have that phenotype, GP100 is not really seen by the immune system. And it's not expressed or expressed in the surface of the cancer cell. So this molecule, the bentafusp, is what's called a soluble T cell receptor. It's a molecule that on one end will bind very, very tightly to GP100, which is in the tumor. So it's that end is going to bind to the tumor very tightly, and the other end will bind to the CD3 receptor, which is in the T cells. So this thing binds to the cell, and then the T cells are circulating, and when they see that end, they're going to bind there, and they're going to activate the T cells and kill the tumors. So you can see here the GP100 is expressed in melanomas, 85% of cutaneous and 100% of uveal melanomas. And here you see how that binding occurs. So this is the normal T cell receptor, and this is the new construct that is soluble. So the soluble construct binds this is GP100 that's being presented by what we call the HLA, and this thing will bind to GP100 and will activate the T cells as the T cells are moving around. So this is the 3-year survival data. This drug was approved based on this clinical trial. There were twice as many patients in the tebentafusp arm as there were in the investigator choice arm. And at 3 years, the endpoint of the trial was overall survival, and there was superior overall survival for the patients that got tebentafusp compared to the patients that got investigator's choice. You can see all along at 1 year, at 2 year, and now at 3 years, there is a superiority of in survival the patients that got tebentafusp. The response rates are not very impressive, 11% versus 5%. But the stability of the disease at 3 months is impressive, 46% for the tebentafusp group versus the investigator choice group. And here, I'm just showing you the side effect profile. This drug does have some side effects that are mostly due to something called cytokine release syndrome. And this occurs mainly in the first 3 treatments. Those first 3 treatments have to be given in the hospital. And you can see here the percentage of patients that have adverse events over time. And you can see that most of them occur in the beginning. And then after that, only a small amount of patients with low-grade side effects occur during this treatment. This treatment is weekly, so it's somewhat difficult for some patients because every week you have to go in and get this infusion. But once you're past the first 3 or 4 weeks, most patients really don't have any significant side effects, and it becomes less of a burden on them. There are other immunotherapy approaches. There is an oncolytic virus called RP2 that is being tested now with or without nivolumab. Brenetafusp is a very similar drug to the tebentafusp, but it targets PRAME. It does not target GP100. You heard everything about PRAME before from the other speakers. And there's also this STING agonist. This is a molecule that stimulates the innate immune system in combination with cemiplimab. We also have some novel forms of treatment, theranostics. Theranostics are antibodies that are attached to a radioactive molecule, usually alpha emitters, and I'm going to talk a little bit about that. So this is the brenetafusp. This is the same construct as I showed you before, but now it's targeting PRAME. PRAME is also HLA-A201 restricted, and PRAME is extensively expressed in melanoma. That's where it came from. It means preferentially expressed antigen in melanoma. That's where the name PRAME comes from. And indeed, it is expressed widely in cutaneous and non-cutaneous melanoma, and also in other tumors that are not melanoma related. So this is the data that was presented by Dr. Hamid in ESMO a couple of years ago, looking at this brenetafusp that's targeting PRAME. You can see that there were some responses were seen in cutaneous melanoma, and in patients who did not have tebentafusp, there were also a good number of patients that have responses as well. If they had tebentafusp before, the responses were not so good. So this data in cutaneous melanoma is now being tested in an early disease trial, or first-line trial, compared to immunotherapy. So we actually have this trial open recently at our center. Unfortunately, we do not have a uveal trial only for this drug, but I'm pretty sure that that's in the works as well. RP2. So RP2 is an oncolytic virus. It's a virus. They have a tropism for tumor cells. It does not survive well in normal cells. This particular virus, in addition, has a CTLA-4-like molecule. And this was presented at ASCO last year. And in this presentation, they used this RP2 virus injected directly into metastasis of uveal melanoma alone or in combination with nivolumab. And you can see here there were responses in about 30% of patients, and these responses were somewhat durable. So this led to a clinical trial that actually just activated as well, and it's going on all over the country in patients who have not received immunotherapy and have had only one prior line of therapy, and that line of therapy would probably be tebentafusp if they are HLA-A201 positive. And these patients will be at random assigned to receive RP2 plus nivolumab versus ipilimumab and nivolumab. So we're anxiously waiting for their result that hopefully will add another option to the treatment of these patients. Let's talk about theranostics. The melanocortin receptor 1, MC1R, is a protein that is expressed very highly in melanoma, as you can see here. It's really not expressed in a lot of other tissues, but in melanoma is very highly expressed. So it's become a target to treat melanoma. And this is the principle of theranostics. So we have a tumor, we have a cancer cell here, and we're targeting a protein. In this case would be MCR1. An antibody can target that molecule and will link this antibody with this alpha emitter, which is a radioactive particle. And there are two that are being tested now. There's one that's actinium-225, and that trial is being done at Moffitt. And there is lead-203, and we're doing that trial with lead 203. They have different characteristics in terms of time that they stay in the body and so on and so forth, but those are both are very legitimate ways to try to treat this patient. So this radiation is taken to the tumor, and in the tumor, it messes up with the tumor DNA. It also messes up with the proteins, the phospholipids in the tumor by creating radical oxygen species, the so-called free radicals. And in addition, once it kills the tumor, it will stimulate the immune system because the immune system will see the antigens of that tumor and maybe develop an immune response in addition to that. So I think this is a very exciting approach as well. And then we have tumor infiltrating lymphocytes and engineered T cells. This is the first trial using TILs to treat uveal melanoma. 7 of 20 patients responded, was 35%. There was one CR that this one here that lasted a long time. And MD Anderson has an experience of TILs as well, only 9 patients. And they seem to have good responses, but the numbers obviously are very small. Dr. Shushtari at the Morrison Kettering just recently presented their experience with TIL, 9 patients. They did not see any objective responses there, but they saw some tumor regressions. So TIL as a thing, it's just the regular TIL that we do, for example, for cutaneous melanoma, so far has not shown a lot of promise in uveal melanoma, but I'm glad that Dr. Hernandez introduced these this engineered T cell therapy from the company Immatics that has really shown very interesting data in uveal melanoma. And again, as you see, PRAME is very widely expressed in cutaneous and uveal melanoma. I'm going to skip to this because he already discussed this, but let me just show you the data that is available. 50% of cutaneous melanoma had a response. Some of these are what we call deep responses. And look at uveal melanoma, 67% out of 16 patients, also with very deep responses. So I think this is a very exciting molecule, a very exciting field, the field of engineered T cells. And you can see here these responses are lasting, durable responses. So the last thing I'm going to talk about very quickly is who is at risk to develop recurrence. How do we know from the universe of patients that come with uveal melanoma who's going to be that guy that will develop recurrent disease? And fortunately, we now have a lot of information that we kind of know who are the people that are at high risk based on a lot of work from everyone globally, and particularly the work of Dr. Bill Harbour from the Collaborative Ocular Oncology Group. And based on the data from the Collaborative Ocular Oncology Group, and this was just recently published, we now know if you look at melanoma-specific survival, we now have 4 different groups of survival, and we have 4 different groups for recurrence, and these are the class 1 PRAME negative, class 1 PRAME positive, class 2 PRAME negative, and class 2 PRAME positive. And as you can see here, at 5 years, these different groups of patients have very different prognosis in terms of recurrence and in terms of survival. So why do we need to know that? We need to know because we need to figure out how to monitor these patients. Also, we may want to give patients adjuvant therapy if they are very high risk. And that brings me to some data that was generated at Dr. Harbor's lab with this drug quisinostat that seemed to work in stopping growth or preventing growth of tumors from uveal melanoma patients. As you can see here, this is the untreated tumor. This is a treated tumor. And based on that, we have opened recently a clinical trial, a multi-center clinical trial for patients that are at high risk based on these criteria. They have a tumor that has a diameter to 12 millimeters or larger, and they are class 2, and they can be treated up to 6 months from the definitive treatment. And our endpoint here is we wanted to decrease the recurrence rate, the distant metastasis recurrence rate at 3 years. So right now, this group of patients at 3 years, 40% of these patients will have a metastasis. What we're looking for is to bring that 40% to 25%. And here are the participating centers. We are open for approval. We are working with all these other centers to get them activated quickly. This is an oral medication that's given 3 times a week for a year, and we monitor patients for 3 years. This is another trial that is open in Europe. It's not yet open in the US, but it will be open in 5 centers in the United States. It's being led in the United States by Dr. Carvajal. This is for patients that are HLA-A201 positive, so they're the only ones that can get the bentafus, and patients will have the primary tumors, and then they will be randomized to receive the bentafus or observation on a 1-to-1 basis. And what we're looking for is we want to see a decrease in the rate of recurrence of these patients that are receiving the bentafusp. And finally, this is in the works. This is a trial that will probably take several months until it becomes active, but this is based on data from the group from Dr. Rapiswan at Georgetown. He did a single-arm trial with a contemporary historical match comparing ipilimumab, nivolumab, and these patients looking at a control group, and the ipi-nivo in these patients seem to have a superior outcome. But again, remember, this was not a randomized trial. So the idea is to make this a randomized trial. Now it's going to be a cooperative group trial, probably a multi-cooperative group trial. So I think this is all I wanted to discuss. I hope I didn't go so much beyond my allotted time here. And before we move on to our question and answer session, Ann Taylor has some words to say about patient resources from AIM. Ann?
Thank you so much. Can everyone see my screen?
Yeah.
Okay, wonderful. Well, I want to start by thanking Dr. Lutsky and all of our panelists for these fantastic presentations, which are much of the information seems to be really hot off the press and filled with lots of hope for the future. So thank you for that. And we've gotten lots of questions. I want to assure everyone you can stick around. We are going to continue to live stream until our panelists have answered the questions that they think are most important to address. I want just a few minutes to talk to you about AIM at Melanoma. If you are not familiar with our organization, we're a patient advocacy group that was founded by Val Guild in 2004. Her daughter, Charlie, was diagnosed with melanoma at the age of 25. Unfortunately, she did not respond to treatment. And after she passed away, Val formed AIM for 2 purposes. The first is to find a cure for melanoma. And there are 2 things that AIM participates in that I want to make sure that all of our viewers are aware of. The first is that Val formed the International Melanoma Working Group, which is a meeting that occurs twice a year with researchers all across the world so that they have the opportunity to share their successes with one another. And then the other is the establishment of 5 tissue banks that are across the United States. We've been collecting tissue from primary tumor sites for a number of years now. We've almost reached the number where we will begin to be able to offer that tissue to researchers for the kind of targeted therapy that Dr. Hernandez was talking about earlier, and we're very excited about that. The second mission for Aim at Melanoma, though, is supporting people who are living with melanoma, those who are going through treatment, but also those who are in survivorship. And so to that end, I want to talk to you about the things that you have available to you through our website. So I'm going to click, let's see if it will go forward. Please go forward, yay, and talk to you about our website. Everything that I'm going to talk to you about is available at no cost to the public. By far, the most frequently visited pages on our website have to do with, let's see, are you guys seeing this bar across my screen? Is that blocking?
No, we're not.
Oh, good. Okay. Have to do with the stages of melanoma, the related treatment, side effects, side effect management, and clinical trials. Another very frequently used service that we provide is called Talk to a Medical Expert. Melissa Wilson is a PA that works with Dr. John Kirkwood at UPMC, and she works alongside of AIM to help patients and get questions answered that they did not get answered by their care team. Usually that occurs because, as we all do, they walk to their cars, they start to open the door, and they remember a question they forgot to ask. These questions are not about your plan of care, but rather maybe something small that was in a diagnostic test, or why one particular, say, a PET scan is being preferred over an MRI. And so she's there to answer those kinds of questions about care. In addition to this form that you can complete where she will try to answer your questions, she has created a webinar series called From the Clinic to the Living Room, where she's taken the questions most frequently posed to her and put them in video form. One of the most frequently viewed videos that she put together is, "I've been diagnosed with melanoma, now what?" And not only has she done a video for patients, but she's done one for caregivers. So I encourage you to go and view those video series. Another thing that we have to offer is a podcast. Our podcast is called Beyond the Clinic, and our host is Dr. Sam Siegel, who is the director of survivorship for KP in San Francisco. She herself is a cancer survivor. And our podcast is not about the clinical questions around melanoma, but rather the emotional experience of being diagnosed with cancer, the isolation that people can feel, the struggle that they have perhaps to build a support community, some of the anxiety that they feel, all kinds of questions. And so we put out a new episode every month, and I certainly encourage you to listen in to those podcasts. They're available not only on our website, but also on places like Apple Plus, where you will most likely find the podcast that you visit. The other thing I want to tell you about is web pages that we have that are support for caregivers. We know that they are involved in many of the decisions of their loved ones. And so we want to tell them not only, support them and give them advice about supporting those they love, but how to take care of themselves during treatment. And then lastly, I want to tell you about Peer Connect, which is our one-on-one mentorship program. We have 62 people across the country that have gone through a mentorship training program. Their role is simply to provide encouragement and inspiration to people who are newly diagnosed. And so if I can connect you with a mentor, or if you'd like to be a mentor, please get in touch with me. And so with that, I will move to my final slide. There we go. So if you have any questions about our website, questions about Peer Connect, questions about our symposiums, then you can reach out to me. I do want to tell everyone that our symposium today will be available in its entirety on AIM's YouTube page, and I will be sending everyone who has signed up today a link so that they can watch it again in its entirety. In about 2 weeks, these presentations will be divided by topic and available on our website. And lastly, I want to encourage you to fill out our survey that we send to you. That survey will enable us as we move to our next symposium with cancer centers in the future, that make sure that we are addressing issues that are most important to you. And so with that, I will stop sharing. I will turn the remainder of the symposium over to Dr. Lutsky and our panelists and let them answer your questions.
Okay, thank you, Anne. So let's we have let's see, we have about 12 questions here. So I think this is for, I guess, any of the medical oncologists. Do we have any studies that show how often recurrence occurs in patients with an NRAS mutation who have responded to immunotherapy?
Well, that stuff, I don't know if I'm aware of any mutation specific data. I know there's been some data published several years ago about patients that had responded, right? So in general, with combination therapy, we think 50% of patients will continue to have a durable response. And then at time of progression, if it's been greater than 6 months, you can oftentimes re-challenge with immune therapy, but I haven't seen anything specific based on mutations. So I don't think, I would say what I advise patients is that we don't think there's any difference in response based on your mutation status with an NRAS mutation. Dr. Lutsky or Dr. Hernandez?
Yeah, no, I agree with you. I think there are efforts to try to, do trials based on mutations. So, I think that's if we have tried immunotherapy and they are progressing, then and we find that there is an NRAS mutation, maybe, we try to find studies that could target, could fit for that population.
Yeah, I agree. I mean, there's some suggestion though that like for BRAF mutations, patients who are BRAF mutating, they respond a little better to combination immunotherapy. But I have not heard anything about NRAS specifically, so I don't think that should be a factor to be treated with immunotherapy or not be treated with immunotherapy. I have a question here about mRNA 917. Not sure about what that is. mRNA 917 trial is a trial for COVID, I think from Novartis, but from Moderna. But I don't. Maybe we didn't get the number right.
Yeah, I think it might be the trial that Dr. McKean was referring to with the Moderna
But that
personalized.
was not 917, so maybe
Yeah,
they,
no, but I don't know if maybe the question is about that because.
All right. So next, what's the benefit on being on a multi-year Nivo for stage 3C melanoma with no recurrence in 2 years? Wow. Who wants to take that? That's someone who's been on Nivo for several years with no recurrence in 3 years, I guess, in the adjuvant stage 3C setting.
I mean, I guess I'll hop in and, encourage that patient that the data in the adjuvant setting has really been for 1 year. And so we don't know that more is better. And if anything, I think some of us wonder if less if even less is actually needed. And that's what we're kind of seeing in maybe the neoadjuvant setting is how can we try to de-escalate treatment. So, I know it's always a hard thing to stop treatment sometimes because there is a comfort sometimes in getting treatment. But I always advise patients, that's why we're going to continue surveillance. That's why you're going to continue to follow with dermatology. But we hope with immune therapy in particular that we've been training the immune system to try to fight that cancer if it comes back, And so this really is a treatment that we have demonstrated the trials, the benefit has been after 1 year. So hopefully you can take some comfort in that about stopping treatment.
Another question about diet, if there's a preferred diet for immunotherapy recipients due to side effects or lowered immunity. So I guess it's related to a subset of patients maybe that have a lot of side effects or lower immunity, whether the diet could change that. I do not believe there's a specific diet that will decrease the side effect profile, but maybe Dr. Hernandez, Dr. McKean, will be the same prudent diet that we recommend, high in fiber,
High fiber,
low in processed sugars, avoid probiotics.
Yeah, and I think the only other thing I'll add is I remember talking to Dr. McQuaid after her talk, and she said that the microbiome for patients that didn't maintain the diet did change back pretty quickly. So I think my lesson learned is you should not be pushing yourself to try to do 50 grams of fiber every day and just push on forward, but trying to find something that fits and is really kind of a lifelong adjustment that you're not completely miserable with.
Yeah, and I think just to remind the audience that the data is a natural fiber, right? Fiber that you get from your plants based, from your Mediterranean type of diet, from your fruits, vegetables, not like probiotics or in commercial that you buy in the stores. I don't think there's data for that. It's actually not recommended. So I think that focusing on the fiber that you can get from your diet, that will be the recommendation.
Here's another question, whether TIL therapy is effective for all forms of melanoma, including the rare forms like uveal or mucosa. So I think I can answer that very quickly. And I showed the data for uveal. We don't have enough data to know how effective it is for uveal, but for mucosal and acral melanomas, there is data that show the response rate there is around 40%. So it's similar or maybe even better than the whole group of patients with melanoma. So the answer for that is yes. How long would a patient stay on immunotherapy like Opdivo or decide to change to targeted BRAF positive therapy approach? It's not really clear what the setting is there. I guess if someone is going to start therapy, we usually recommend starting with immunotherapy because there is a lot of data showing that sequence is better. There's some exceptions of patients that may get a short course of targeted therapy, but in general, you want to start with immunotherapy and just change if there's progression of disease. Any other comments, Dr. McKean,
Yeah.
Dr. Hernandez?
No, I agree. I think we start in BRAF mutated melanomas. We start with immunotherapy most of the time with combination therapy if the patient can receive it, and then if there is progression of disease or side effects, severe side effects, then and maybe that patient we think that should continue receiving therapy. Then at that point we will switch to a targeted combination therapy. But I think immunotherapy first, and then at progression, switch to other therapies.
There's a question here about the RP1 status with the FDA. So I guess we were all expecting this oncolytic virus therapy to be approved, and it was not. But I think my understanding is the company is answering all the questions that were raised by the FDA and will resubmit. I think there has been a lot of letters from providers and centers sent to the FDA to look closely at this, but I don't think we have an outcome yet. Another question asking, where are the engineered autologous T-cell therapies available? I would suggest, I mean, you look in the company website or in clinicaltrials.gov, it will list all the centers that are currently doing those clinical trials.
Yeah, it has to be through a clinical trial. It's not yet
Right.
approved. So you have to be enrolled in a clinical trial in order to participate.
Another question, TIL appears to be very effective. Why is it only offered after immunotherapy? Is there benefit to receiving immunotherapy first? I think we all would say yes here, right? Immunotherapy first. There's a clinical trial that's looking at that.
Right. Right. I think with the data that we have so far, we give immunotherapy first and then if they don't respond, then they can be treated with TIL. And there's a trial ongoing in the first line setting, but at least until we have those results, we do immunotherapy first.
Yeah, I personally have a concern about doing TIL first. There is some data that has been presented, in an abstract form, retrospective data suggesting that patients that progress on TIL have a very low response rate to immunotherapy after TIL. So
that's why, we have to wait and see how those patients that get TIL first, how do they do, after they're followed for some time.
What is your opinion on that, Dr. McKean?
Yeah, I agree. I mean, and it's just, the nice thing is immune therapy, you can get it started quickly, right? We know it can be relatively effective. And so that's why most of the data has been in the second plus line setting. So, I think it'll be interesting to see the patients that get enrolled on the frontline study. And, if that's a young patient population that was pushing for TIL up front, and we'll see. But I think, the fact that like ipi-nivo, the combination therapies, you can get those started relatively quickly and know within, weeks sometimes if a patient's going to respond or not. That is just advantageous usually to start with that.
Yeah, there's been a lot of hype about TIL. We all like TIL. I think it's a great, addition to our armamentarium. But remember, it's not a picnic, and people do die, as a consequence of the therapy. So you gotta keep those factors into consideration. Dr. Tang, how do you follow up on Mohs removal of melanoma in situ on the cheek? Do you test gene expression and do full genetic profile? Do the results help to predict recurrence?
So for the most part, we follow with the good clinical exam. So with the total body skin exam, palpating lymph nodes, again, every 3 months for the first year, and then you can increase the interval thereafter. Typically, the gene expression profile tests are not ordered for in situ melanomas. Even the company, recommends it's mostly for invasive melanomas. And it is a tool that we've spoken about to help predict recurrence. What we do with that, there's not a lot of data that guides us in terms of what to do with that information yet. And then I think you're referring to genomic sequencing of melanoma in situ, and that I would say is almost never done. The reason that people get sequence of tumors is to help predict treatment treatment. It will help guide treatment for systemic therapy, and usually that's not the case for melanoma in situ. So it would definitely be an overutilization of resources.
Thank you. Another question. Once diagnosed with uveal melanoma, would it be prudent to consider removing the eye as a precaution? No, I mean, we're trying to save the eye here most of the time, and there is absolutely no data that shows that enucleation is better than our current treatments of the primary tumor. There's really zero data to favor that. If someone does not need enucleation, they have a functional eye with vision, you want to keep it that way. And last question here, does targeted therapy carry a higher risk of adverse reactions versus immunotherapy? Who's going to take that?
I can hop in, and I mean, we could probably talk about toxicities all day, and just the differences. And I think in general, they're just different in targeted therapy. The advantages, fever, chills, rash, diarrhea, even vision changes in general. If you hold therapy, those toxicities resolve fairly quickly versus immune therapy, just by nature of getting the immune system revved up, it can generally take longer for those to resolve. So I think when you look at the trials, almost every patient, with whether it's targeted therapy or immune therapy, has some toxicity, whether that's a rash with immune therapy or not. So I think it's just very different profiles.
Yeah, and if you look at the discontinuation data from those trials, they're very similar for immunotherapy and targeted therapy. So that, like you said, just different toxicities. Okay, I think we answered all the questions we had on the chat here. So I want to thank everybody from attending this conference today. I want to thank our panelists. I want to thank AIM and Melanoma for putting this together. And I definitely want to thank Cristina Esteves, who is our programmatic director for our melanoma program, who has done a great job helping to put this together. Anne, do you have any final words to say?
No, that's it. Thank you to everyone. Thank you to our panelists. Thank you to everyone who viewed. And don't forget that the symposium is available again in its entirety on AIM's YouTube live page. And have a wonderful weekend. Thank you all.